Okay, everybody. Again, if you're just joining, let us see your faces. We are going to kind of go over, for those of you that are new to how we do this in the Focus Academy, because we are kind of hosting it with our processes here. We have Bree, our amazing admin, who's going to run this for Dr. Marty and I tonight. Dr. Marty and I are really excited, and Nancy, we're really excited to be able to do this. We've been talking for, I don't know, Doc, we've
Weeks, months, actually.
yeah,
Back
yeah,
and forth. Yeah. I keep seeing little IMs popping up going, oh,
yeah,
there's Amy.
yeah, yeah, exactly. We're just old friends now, but we started to see that a lot of people that were interested in the work that we're doing in the Focus Academy in the pediatric world are also, studying under Dr. Marty and Nancy and Dr. Nancy, and people that are doing both, people that are in both camps, like really are getting this very well-rounded lens and really enjoying it and having a lot of success. And so I started going, hey, I wish every single doctor that worked with us also was trained by you guys. And I know you were starting to see that.
Yeah, our thing was that we used to work with the Institute of Achievement and Human Potential doing programs with kids, and now we don't do that anymore. We don't have the time, and so we're always looking for somebody. Once you make the adjustment and clear up the nervous system, then you have to rebuild it, and that's what your program does. So that's what we've been looking for, is someone to help instead of in my office again, just because I've been there a long time and I'm not willing to take on any more staff. We're kind of semi-retired in the office. So we needed a program to outreach so people who, once you got the nervous system cleared, can then retrain the brain and retrain those neuroplastic patterns.
Yep, that's right. So this is fun for us. We have a lot more in the future coming, but we also wanted to make this just sort of an end of the year fundraiser for Sherman. So any profits we're making from this are not going to either of us or our programs. They're going to Sherman, to the intern program, to help new interns transition into seeing patients in the clinic. So I know we are both pretty excited to support Sherman and their new president, of course.
That's right. They got a new president. I actually went, did you know I went to Sherman first?
I did.
Yeah, I went there for a year. That's right. They got a new president.
Yes, Jack.
Yeah.
And he is very excited about both of our work as well. So lots of good stuff coming. So we're going to have the GOAT here start off with his presentation. And I told him, you just do whatever you want to do. You teach us all the things, Dr. Marty. And then I will bring the way I work, which is I'm going to talk about later development and kind of how I put things through a simplified lens to put them into practice. So Dr. Marty, thank you. Take it away.
Thank you. I'm going to put on my little slideshow here for everybody. So what I'm going to do is I'm going to talk a little bit about the development, the pediatric development. I'm going to really want to get an idea of, across you, of how important the neurological development is, especially in the first year. So my ball game is adjustments. My ball game is the art of chiropractic. That's where I've always spent my focus. That's where I've done much of my teaching. But I also understand that to perform the art of chiropractic and be able to do that, you have to have a philosophical construct and a scientific basis or construct to know where you're coming from. So when you're talking to patients and you're trying to get them to understand what you do, there really needs to be a way to connect. And the first way to connect is for you to get the idea of how important this process is to you, and then you can convey that to your patient. So what I want to talk about is the importance of the proper development of the central nervous system, especially in the first 2 years of life. We're actually talking a lot, and we teach a lot about the pre-ambulatory infant. And the reason for that is that we're really talking about some developmental milestones that have to be laid down and set in stone so that the proper neurological development can occur for the rest of the child's life. So at birth through age 1, we are born with all the brain cells we need. In the first year of life, 90% of the gray and white matter are present. Myelination of the white matter proceeds rapidly after birth. So the general pattern of adult myelination is present by the end of the second year. Now think about that. Basically, what you're doing is you're laying foundations down there. You are developing 90% of the substance in your nervous system that you can use for the rest of your life. And then the next step is creating synapses. And that's what input comes from. The body is constantly taking in information, creating input. In the first year of life, you can create between 1,000 and 100,000 synapses per neuron. And the more synapses you create, the better off you're going to be later on, because what happens is the old adage, either you use it or lose it. what happens, you start to prune off synapses that you don't use over and over again. So through the developmental phases, what we're really doing is laying down a baseline foundation. This elaboration of new synapses in the first 2 years of life corresponds with an increase in the overall gray matter. So in this period is the greatest number of and fastest development neurological connections and pathways are being created. So think about this. What we're saying is you're laying down the foundation. If you were building a city and you wanted to put 250,000 people in the city, and you built the infrastructure, and you built the houses, you built the plumbing, and you built the power grids. And then what you did is you left that city alone, and over the years, you forgot that humans propagate. So in 5 years, your city was now 750 million. And in 10 years, your city was now 2.3 million people. But you did not build the proper underpinnings. You did not proper baseline. And what happens is the city starts to break down, which is what happens to nervous systems. If you don't build the proper baseline, as the children get older at 4, 5, and 6 years old, when they have to call in more of their nervous system and have to more intricate pathways, if there is not enough baseline, the system breaks down. And then we call that some disease process, and we give it a name. ADHD, ADE, sensory proprioceptive, sensory integrative. It's all the same thing. It's a nervous system that is broken down because the baseline has failed. The peak synaptic growth period is at 8 months. That is the fastest time that your body is building pathways. The first 8 months of your life, and in 8 months, you are building more synapses and more pathways, making more connection in your brain than you ever will ever again in your life. By the second year, the general pattern of adult myelination is present. And what happens is not only are we talking about the nerves being able to be connected, but at the same time, what we're developing a wide range of cognitive and motor functions. So we're integrating our knowledge, our brainstem, our cognitive, and our baseline motor functions based in the cerebellum and moving through different parts of the brain, which we're going to discuss in a few minutes. The cerebellum is your mainframe computer. Everything passes through the cerebellum. It is so important that it grows 240% in the first year of life. So think about that. The cerebellum itself increases 240% because it is the gateway. And it is a prerequisite for specific aspects of later cortical development. If the cerebellum gets input that is too much or too little, and it overloads the cerebellum, just like in your office, if your mainframe computer starts to break down or can't get process the information, the peripherals break down. In other words, all the other computers are useless unless the mainframe is working right. And this is what happens in the cerebellum, where it's located in that area in the base of the brainstem. So the period from birth to age 2 is the most dynamic and important phase of postnatal development in humans. Again, cognitive and motor development form in early childhood, as well as the potential pathogenesis for neurodevelopmental disorders. So what this means, and what often happens when you're in practice, a parent will come in with a 3, 4, 5-year-old, 6-year-old, 8-year-old, whatever the child is, and they're having neurodevelopmental issues, processing issues, learning issues, behavior issues, whatever those are. And when you start to do an evaluation or you start to do your intake, your case history intake, you'll often find that the parent, especially the mom, had noticed that there were some issues prior to the first 18 months of age, especially if she had other kids. She noticed there were glitches in the way the child developed. And so as they started to call in more of their nervous system, what happened is as the system broke down, they started to have more difficult time. Let's say they went to school and they had to create more input, more interaction, use their prefrontal cortex. And because the pathway was broken, they couldn't adapt. And because they couldn't adapt, then they got diagnosed with a particular condition or disorder because the pathogenesis had started early within that first 2 years of life and didn't express itself until the system was stressed. So this rapid pace of structural brain development and equal rapid development of the wide range of cognitive and motor functions. Now listen to this. This is what's really important. And this is what we're talking about. It sets the baseline time frame for future developmental potential on all levels. In chiropractic, we talk about human potential. Well, where else can you actually stimulate and perfect human potential than in those first 2 years of life? When a 40-year-old or a 50-year-old or a 20-year-old comes into your office after years of neurological insults and have issues, or they come in for whatever issue or complaint, they have already reached their underlying neurological potential. So it is in early childhood when we get the opportunity to actually make the true promise of chiropractic come in to play, is to make the optimal potential of the nervous system. There is a large increase in the brain volume in the first year, which means the first year of life, your brain grows 101%. By the second year, it increases another 15%. And this simple fact suggests that there is a pressing clinical need to identify children at risk for developmental disorders within the first year of life, and at that time initiate appropriate interventions. Once we create positive or negative neurological pathways, as the child gets older, you're going to see in a few minutes, when they start to hit 6 years of age, it becomes much harder to change those neurological pathways. The sensitivity of an infant's nervous system, especially in the first 2 years, is set to download information. And so what happens is we have a different vibration in our brain. It works at a different vibrational level as we get older. And we're going to talk about that in a second. But you have to understand that whatever input you're putting in, this is an open computer, basically. The brain is an open computer. It's like going into a store and buying a new computer and trying to fill it with software. That's basically what you're doing in the first years, two years of life. You're taking the system that you bought, which is in the gray and white matter, the synapses, and you're feeding in software. And this sets the baseline for the infant's response and for thresholds for years to come. So when you see a family, let's say, of 3, 4, 5 kids, and you can see that the neurological developmental process in each kid is somewhat different, but their response is also different, it's because how they've learned to adapt to those neurological responses when they reach a certain threshold. For example, what I usually talk about in seminars is I grew up in New York City. My wife grew up in a town called Concord, New Hampshire. I also drove a taxi when I was a kid in New York. So my nervous system, when it comes to being in traffic, gets to be aggressive. My wife, on the other hand, when she's in traffic, she tends to just kind of chill and let people do their thing. And the point of that is it is the same stimulus. We're in a lot of traffic, but the way we react to it is the way we were brought up. It's where our nervous system was timed or tuned to be brought up. So when you have a little kid who goes into a mall, let's say, and there's a lot of noise and a lot of sound, and a lot of lights, and sometimes some little kids will just shut down. They'll just close up. They'll try and hide. They want to get out. They can't deal with it. Other kids will get very aggressive and start to hit and bite. It is the same input. It's the same broken nervous system. It's just the way that their body has learned to react to that. So in the first 2 years of life are the most influential period of postnatal development. At no other time in our lives is the expression and development of human potential so greatly influenced and developed. I say this over and over again because I know in a lot of places, and sometimes even in schools, they really don't teach you how to work with or deal with the pre-ambulatory infant. You don't get the tools, you don't get the examination findings, and this is where we really can make our difference. And I've been in practice 40 years. I have 4 generations of patients now. I take care of the parents, the grandparents, the great-grandparents, the infants. So I take care of them because they've been under care for literally some of them 40 years since I've been there, or 35 years, because they started when they were little kids, and it's actually imprinted in their nervous system. So let's look. Year 1, 1,000 to 100,000 synapses. Brain grows 2.5 to 3 times its birth size. The total brain volume increases 101% in the first year, with 15% increase in the second. Cerebellum, 240%, it grows in the first year. By age 2, 80 to 90% of the adult volume of nerve cells, especially gray matter, are present. Now, what happens, and we're going to see in a minute, and I'm just talk briefly about it because this is going to be kind of Amy's ballpark. By age 6, 90% of the sensory and motor integration occurs. So what you've taken is you've taken that raw material, and over the next, after age 2, you have that raw material. For the next 4 years, you're integrating whatever you have. So you're basically doing the best you can with what's been happening in those first 2 years of life. So what are the influences on the growth and development that can inhibit the proper development of the central nervous system? Birth process. Sometimes optimum doesn't always happen. Any alteration to the optimum position may cause distortions, imbalances, potentially resulting in any one of the following: abnormal molding of the cranial segments, which is kind of what we talk about when we talk about the cranial dural meningeal system, obstruction of blood flow within the vascular system, abnormal pressure within the cranium, which affect brain cells and cranial growth patterns, torsion and twisting of the connective tissue in the spine and cranium, abnormal muscle tone, skeletal subluxations or misalignments. Now, one of the things that I want to talk about, and I really want you to get here, is when we talk about people getting subluxated, Very often, especially if patients come into your office, they think of a pinched nerve. They think of a pressure on a nerve by the foramen misalignment, disc degeneration, exostosis, ankylostosis. They always talk about nerve root compression. Well, that's not the case in the pediatric practice. Matter of fact, the primary mechanism of injury to the spinal cord appears to be excessive traction applied to the spinal canal and cord during the birth process. 95% of the subluxations you will see in the pediatric practice are traction subluxations caused by hypermobility of the joints, not fixation subluxations, which we're often taught to find. We're often taught to find the fixation, but we're not taught to find the hypermobility, which creates a neurological input and creates positive muscle control in other areas that create fixation, which are actually compensatory. And the other thing about nerve tissue is when it's stretched, due to hypermobility of the spine, and that nerve stretches, it causes immediate pathophysiological changes as well as long-term neurological, pathoneurological changes. So basically what we're saying, when a nerve root gets traction, if we continue to leave that nerve root under traction, it will, number one, stop firing correctly. And number two, the longer the traction stays there, the better chance there is going to be long-term neuropathological changes. So again, those patterns are going to be set once that traction occurs. So subluxations can create afferent input into the central nervous system. We are tuned to determine between pain and pleasure by the third trimester in life. Third trimester in utero. By the third trimester, a baby can differentiate between what causes them pain and what causes them pleasure. So subluxations will increase the afferent input into the central nervous system. They lower the adaptive thresholds. They cause lower adaptive ability. They create hypersensitivity to what is normal stimulus, and they can act as a pain response, causing less imperfect compensations or adaptations to be integrated to the nervous system. And this is the important part. These adaptations get integrated into the nervous system, so that is how they adapt to situations. It's kind of like the example I just gave you about, driving in traffic. Whatever the child learns to do that makes them feel better or works better for them, that becomes a compensatory adaptation when they reach thresholds. So they no longer have what we would consider a normal response. It may be common, especially if you think of things like autism, right? What's the autism rate right now? It's 1 in 38 or something like, which is insane. When I was in school, it was 1 in 2,500. So what we're doing is we're seeing a bunch of children becoming common responses, which are hypersensitive responses to normal stimuli because their nervous system is under distress. So when the brain is developing, it develops with inputs being much more important than outputs over those first 2 years. There are two states we're going to talk about, delta and theta states, and they are what we call unconscious weighted states. They are happening in the first 2 years of life. These unconscious weighted states allow the brain to take in huge amounts of information without making conscious decisions about them. Around age 6, the child becomes what we call conscious based on EEG findings in the brain. So the first 6 years, the child is downloading programs into consciousness and then uses them to interact later on. This is just another way of saying what I said earlier, is that you lay the baseline in the first 2 years, and then from age 2 to 6, you integrate that baseline. So if we look at a chart at brain activity, at brain frequency, we can see these are different states of consciousness when we measure brainwave patterns. So we're starting at delta, which is sleeping unconscious, theta, alpha, and as we move on to these higher levels of consciousness, they also take more input. They also take a more integrated nervous system. It doesn't take a very integrated nervous system to sleep or to be in kind of what we call this imagination state. As we start to move into the alpha state, that's when we start to use our prefrontal cortex, and the brain then can be able to make things like focused conscious decisions and also create peak performances. But these waves depend on the ability of the body and the brain to adapt. So for example, if delta is someone who's trained to run a 10K, which is about 6 miles, and gamma is someone who's trained to run a marathon, what happens is if you stay in this training mode, if you can't get the brain to work and you're working at this level of, let's say, a 10K, and you try to push it and run a marathon, somewhere in that period of time, you're going to crash. And that's what happens to kids' nervous system. They're at home, maybe they're younger, they're staying at home with their parents, or they're going to a small preschool, and then all of a sudden they get pushed into a larger school, maybe a kindergarten or first grade, where they have to adapt more, they have to take in more information and process more information. Well, because their nervous system can only function in these lower brainwave frequencies, because their subluxations or interference or the threshold is lower, they break down and they fail to make it into those next levels of performance. So the cross-up point or the breaking up point, which is why I spend so much time talking about it, is right here. At 12 to 17 months of age, these are the type of motor functions that you should see in a child. So we talk a lot, and I'm not going to spend a lot of time talking about milestones, but this is when the milestone developmental process occurs. So what we're looking at is the ability of the brain to right here be at a place where it can start to integrate the information. This is motor functions, and then this is sensory functions. If at this point in time, the child is not able to make or reach this level of integration, the odds are that as they go through these next phases up to age 6, which is what we talked about, is there's going to be compensatory patterns and breakdowns in the way their nervous system functions. And that's why I say often when you talk to parents and you ask them when did they notice the child was having a problem, they will say that usually somewhere before this period of time, they noticed a glitch or something wrong, or the child wasn't developing, or they missed a milestone or whatever it is. They will notice it. This whole process. And also the other thing about this point right here, when we talk about primal reflexes, the last primal reflex to dissipate is Babinski, and that usually should be gone by age 2. So right at this point, the body is no longer necessary to have these primal reflexes, because the prefrontal cortex should be starting to kick in between age 2 and 3, and therefore the need for these primal survival reflexes should dissipate. So again, the compensatory changes we see is if the child does not get integrated at this point in time, they will retain these primal reflexes because their prefrontal cortex is not able or is not mature enough to basically be able to override those primal reflexes. So sorry. I went the wrong way. Hang on, give me a minute. Thank you. There we go. So by observing behavioral patterns of people in their immediate environment, children learn to distinguish acceptable and unacceptable social behaviors. They start to process this after age 2 to age 6 is where they really start to integrate what is acceptable and unacceptable behaviors, because they've learned to basically deal with and manipulate their environment. So in my world, the most damaging thing that we can have in the nervous system is a subluxation. It interferes with the optimum function of the nervous system, affects overall health of human beings, changes abnormal brain and CSF function, changes transmitter, just creates neurotransmitter dysfunction, changes quality, quantity, and speed of nerve impulses, changes the brain temperature, can affect nutrients to the brain, waste material. So basically the subluxation is the overall process that will decrease the optimum potential and function of the nervous system. And we're going to talk in a minute about the different areas or levels that it can affect that create these imbalances. We talk about the primary subluxation. The primary subluxation is basically that subluxation that occurs within the sacral-occipital respiratory mechanism, or the mechanism that controls the motion of the sacrum and the occiput and the movement of cerebrospinal fluid and the tension of the dural meningeal system. It's called primary because the primary system is working while the child is still in utero. So it is the relationship between the movement of the sacrum and the occiput and the attachments to the dural tissue and the movement of cerebrospinal fluid and the tension that Dura creates as it attaches to the epineuron of the nerve. The secondary respiratory motion is diaphragmatic. So when a child is inside the mother's uterus, they are having primary respiratory motion. The first thing that happens when they exit the birth, either exit the birth canal or exit the uterus, the first thing the child does is take a breath in. And the last thing you do on this planet is take a breath out. And that is the secondary respiratory motion. Those mechanics are based a lot on structural underpinnings, fascial systems, whereas the primary system is really based on the dural meningeal system. Major DeJarnette, who was one of my mentors, talked about the subluxation. And what's different about a subluxation, we're not talking about a bone pressing on nerve, is that a subluxation actually produces abnormal stimulus, which then affects the musculoskeletal system and can alter the total makeup of the intervertebral foramina through the total length of the vertebral system. It is not necessarily one resulting from a changed attitude of one vertebrae in relation to another or many other vertebrae, but this is where it's important. It is the result of meningeal bulging, traction, overlapping, tearing, inflammation, or one of many other processes. The total dura structure is under tension, with the resultant neurological dysfunction developing at the spinal cranial area under the greatest stress. So what he's saying, and we've been saying, is that when you have a dural meningeal stress pattern, it creates tension throughout the entire system. And most of the time, the resulting subluxation is one of traction, which we talked about a minute ago. And that traction causes immediate pathophysiological changes in the nervous system ability to compensate and to function. Subluxation of the atlas occipital region or the atlas axis area will cause this primary respiratory mechanism to distort and cause abnormal stress to the meningeal system. The reason for that is because some of the strongest attachments to the dural meningeal system before it goes into the cranium is around C1 and C2. And then the dural meningeal system comes up into the cranial vault and through the sutures of the skull. Almost all of these subluxations occur before the 7th year of life. Now, we know that that's actually not true. They actually almost always occur before the 2nd year of life. And the difference is that the subluxation produces an abnormal stimulus. And that's what we're looking and need to learn to find out is where is the abnormal stimulus. Jeanette said the only true subluxation you must ever see is in a child prior to 7. And again, this is what we said over and over again. The subluxation is an actual vertebral misalignment with muscle protectors, but if it goes uncorrected, it is a primary source of stimulus through life. Now, he wrote this in 1967. He graduated chiropractic school in 1924. So he was kind of ahead of his time when he talked about pediatrics and chiropractic. But this is where that subluxation can occur. And this is what happens. When we traumatize the suboccipital structures, it inhibits function of the proprioceptive feedback loops. Now, these feedback loops are pre-programmed. They're motor developmental program feedback loops that allow the body to adapt to its environment. So they are the pre-programmed proprioceptive feedback loops that trigger the visual proprioceptive righting reflex when you hold your head up, that allow the baby to turn over, that allow the baby to sit, allow the baby to crawl, allow the baby to walk. Those are the pre-programmed. They're pre-programmed in the nervous system that are supposed to fall within a certain time frame and follow a specific pattern. If they don't, because we are fault-tolerant human beings, we will overcome this and we will adapt. But this adaptation creates difficulties in restricted working conditions. And what we often see manifested, which is the kind of work that Amy gets to do all the time, is that we see these kids who are now hampered or having functional issues, and that they've missed that developmental state, and they've made compensatory changes. And the price for this that they're paying is a reduced capacity to absorb stress later. So that's what we talked about. We have a nervous system now that is unable to adapt to those additional inputs and that additional stress, and it starts to break down. Then symptoms start to occur. Anything from headaches, postural problems, or diffuse symptoms like sleep disorders, or being unable to concentrate, or being unable to process information correctly. Again, it's a compensatory state that occurs when the suboccipital structures, which are pre-programmed, and also into that area of the cerebellum that we talked about, gets damaged, gets aberrant input, either too much or too little, and that system will then tend to break down and create compensatory changes. So which are the systems that we're talking about that play a major role in that development? So we want to talk a little bit about the brain, but very little, because you're all students, you're all chiropractors. But I want to talk a little bit about the pathways, because the pathways are what we need to work with and learn to evaluate. So the cerebellum is what we call the primal brain or the hindbrain mode. And it is the input receptor. It communicates signals for the rest of the brain. Remember, this is your master computer. It is located and it's at the medulla, and we have the cerebellum, and we have the pons, and we have the spinal cord, all meeting at that base of the brainstem, right at the exit of the frame or entrance of the foramen magnum. So stress on that area, especially C1 or C2, can cause that dural meningeal stress pattern to affect the cerebellum. It controls vital functions, it organizes motor reflex, and it has those pre-programmed proprioceptive feedback loops. The second level, or the second communication area, comes into the parietal and temporal area and up past into the occipital cortex towards the midbrain. And that integrates the input. So once the input comes in, it gets integrated in the midbrain. It's a relay station for information and for memory. It helps regulate behavior. Okay, and it has the pleasure or pain response, which you talked about a little while ago. It coordinates responses to your nervous system or to your environment. Now, the prefrontal area is the area that helps process and control that information. So if there's not a proper connection that goes from the cerebellum to the midbrain, to the prefrontal cortex, so you can make decisions based on the input in that midbrain, then the system can break down. So if you have kids who go from 0 to 60, get really irritated, start screaming right away if something doesn't go their way, it's because they're stuck in that midbrain level. They are stuck in that emotional level. They're getting input from the cerebellum, it's feeding into the midbrain, and it's not getting to the prefrontal cortex. They can't make the decision because the prefrontal cortex connects back into that limbic system. So if you're in a situation where you get angry, upset, that you can stop, you can think, you can control yourself. Well, a 2-year-old, a 3-year-old, a 4-year-old, if that link hasn't come in, they will tend to act out. They will not have the ability to basically make cognitive or higher processing decisions if that pathway is broken. So when we talk about cranial dysfunction and talk about cranial adjusting, we talk about following the pattern from the primal brain survival mode, or those pre-programmed proprioceptive feedback loops, to the midbrain, which is where our emotional level is. And we're talking about then working with the spheno-basilar system and the limbic system. And then finally, cortical function, which is higher level integration. We're talking about dealing with the frontal bone and the cerebral cortex, which is why I find it so important to do cranial work. Well, you're looking at the skull of an infant. In this position, with the fontanelles open, the job of this skull is really not to protect the brain, but to allow the brain to grow. This sutural system, if you look at that sutural system, as the duromeningeal system attaches inside the cranium, it also comes up into the sutural system and forms the sutures of the cranium. So while we are dealing with a child with these open fontanelles, we are basically dealing with an open system that's whole purpose is to allow for optimum function and development of the central nervous system. If there is aberrant stress on the duromeningeal system, when it attaches into these cranial bones, it's going to change the way the cranial bones form. It's going to change tension all the way in the duromeningeal system, all the way down to the sacrum. So this is where 80% of your central nervous system is located, in that cranium. During the period, the cranium is designed to support the growth of the brain. As I said, 101% in the first year, 15% in the second year. Distortions in cranial growth patterns can stress the duromeningeal system, reduce CSF flow, change cranial growth patterns, and create abnormal pressure on the neurological tissue, both the gray and white matter. They can decrease its function. So the dura attaches all the way to the circumference of the foramen magnum, second and third cervical vertebrae, to the posterior longitudinal ligament, and then the tube ends at the second sacral segment, where it attaches to the filum terminale. As each spinal nerve exits the intervertebral foramen, they are connected by prolongations of the dura. When we look at the system, this is the duromeningeal system in the cranium. Its whole job, as I said, is basically to allow for normal cranial bone growth and development, but it is also job is to allow the brain to reduce its actual weight. So the brain weighs about 1,500 grams, and this reduces it to about 50. The duromeningeal system is a contiguous structure that attaches from the filum terminale into the coccyx all the way up into this duromeningeal system in the cranium. When we look at the system, this is what it looks like. This is our occiput here. This is our spheno-basilar junction. This is, again, the atlas vertebrae. So you can see any motion in any area of this duromeningeal system will affect the entire system all the way down. Here's your arachnoid matter, the dura matter, and between this is the subarachnoid space where the movement of cerebral spinal fluid occurs. So what I want you to look at is when a child is breathing and moving in and out, this is what the cranium is doing. If you look at the top, the sagittal suture there, you can see the dura stretching and releasing. It is supposed to create a certain amount of tension. This is what we call secondary respiratory motion or respiratory motion, and it is bilateral by the fact that every time you breathe in and breathe out, the cranium and all the bones expand and contract. Underneath this is the primary respiratory mechanism, which is the motion of cerebral spinal fluid, which is the fluid system that helps to protect the brain, bathe the brain, and create, remove waste products. It is the main lymphatic system of the central nervous system. What we're talking about here is two things. So what happens with the dura during this phase is this is your falx cerebri up here. This is your tentorium cerebelli. You can see one of the things that I love about this picture is you can also see when we're dealing with kids with nursing or tongue-tie issues or palate issues, part of the way the spheno-basilar, which is this junction right here, moves is by the palate being able to move up and down. So that's why it's also so important when kids are nursing or sucking or trying to feed that the palate is able to move, the back part of the palate is able to move. But this dural meningeal system is affected by the two things we talked about. Primary respiratory mechanism, which is the flow of cerebral spinal fluid, which is controlled by the production of cerebral spinal fluid in the choroid plexus. And the second is the secondary respiratory motion, which allows for more cerebral spinal fluid to be available, but does not alter the speed of the movement of cerebral spinal fluid. So I'm going to come back here. So the other thing I just wanted to look at is this picture right here. This is the motion, what we call the reciprocal motion between the sacrum and the occiput. Every time the sacral base goes posterior, the sphenobasal mechanism rises up. And this motion helps move cerebral spinal fluid up from the lumbar cistern into the cranial vault and into the ventricles, lateral, third, and fourth ventricles. So as the ventricles get filled up, they reach a certain set point, and when they reach that set point, the choroid plexus has stopped producing cerebral spinal fluid, and they start to shrink the ventricles, and CSF will then flow down into the sacral well, and as that expands to a certain point, the sacral base will then, when it hits a certain set point, will start to push back, and this is the reciprocal motion of the primary respiratory mechanism. So, as a chiropractor, you have to begin to change the conversation. What you have to do is you have to educate your patients. It is really the only way to be able to build your practice and build the profession. You have to shift the paradigm from symptom care to creating a healthy child. What is common is not normal. That's the thing that happens these days. People, everybody has colic, everybody has flagiocephaly, there's a whole, the American Medical Association says that 47% of children born today have some kind of cranial distortions, but they only suggest treating 10% of them. So that's pretty crazy. So we're talking about common is not the same thing as normal. So we talk about knowledge, responsibility, and commitment. Once you have the knowledge, it gives you a moral compass that should lead you to a certain level of responsibility. And the responsibility is to take action. The effectiveness of the process is based on your level of commitment to the task. So once you understand what it's all about, understand the importance of the first 2 years of life, then it's about the level of commitment you're willing to make, and that is the amount of energy that you're willing to commit to the process, and it is proportional to how you will succeed. The more energy you put into this process, the more you will succeed. The more your patients understand, the more you will get better outcomes, and the more you will be able to basically build your practice from inside. If you do not have a technique in your current practice paradigm that positively affects the movement of cerebral spinal fluid and the dural meningeal system, then you're not being as effective as you can be in creating optimal environment in your patient's nervous system for healing. And that's kind of what I do and Dr. Watson does, and that's what we do with our Peak Potential program, is we help train chiropractors. And that's our job, is to help train chiropractors so that they can actually deliver the adjustment, know when they're making the adjustment, and be more effective in helping set the potential of the children that we get to see in our office. I'm back.
Hello. Thank you so much, Dr. Marty. I think we can open it up for some questions, but this is good timing. I don't know if you're done or not. I think you're done.
Yeah, I'm done. No, it's it. I'm done.
Okay. Okay, great.
Did I do well? Yeah, I think we're good,
did.
right?
Yeah, you did. You did good.
Okay.
So with your timing, which I know is always tricky for all of us, but
Yep.
This is good timing because Bree is putting up a survey questions.
Okay.
Bree, is it working?
Yes, I just put up that first question. I think some people were able to open it and some were not. So maybe if you just copy the link and paste it into your browser, when I click on it, it opens. So it might just be your computer settings. So go ahead and give that a try. And then I'll be posting the second question like sometime like after 9 o'clock. 9 o'clock Eastern time.
I'm like 9 o'clock.
Yeah. Late over here. I'm on Eastern time. It's like in 20 minutes.
Okay, so speak up if you're having trouble with that survey. Go ahead and like unmute yourself and let us know if you're having trouble opening that still. But it looks like a lot of you have gotten it. And Dr. Marty, if you're okay, if people have questions, I have a couple of questions for you. But if people have questions, I think that we have some time to do that before I jump in. So the way we'll do it is literally just unmute yourself and we'll try to manage you guys.
Scream it out.
Yeah, scream it out. Oh, okay, then I'm going. So, I've been in practice 15 years, Dr. Marty, and I was in the kind of neurooptometric world my whole life. So we have a lot of chiropractors that are raised in chiropractic families, and, your worldview is shaped, where by your parents and by your life experience and all of that. So in my world, I always was very involved with neurodevelopmental disorders and deflected learning patterns. So that's what I see, and that's what I've always seen in practice, right? In your experience, because you've been in practice, a long time.
A lot longer, yes. It's okay.
A lot longer, yeah. And so I was trying to be nice there, but
don't worry about it. You met my wife,
have you noticed a big difference in the severity of the younger kids under 2, and also deflected learning patterns and behavioral patterns later in life? Talk to us about your experience in practice with that.
The last 15 years, which is interesting that you've been in practice about 15 years, I would say it is scary. And what's scary about it is, so I remember saying, we used to get kids with neurodevelopmental problems or processing issues, integration issues, or anything like that with a family for maybe one kid, and maybe every 2 or 3 families, it would happen. Now we get families with every kid who has neurological dysfunction, and they're deeper and they're harder to deal with, and they're less integrated, and the parents are more stressed, and the situation is building more and more. And it definitely within the last 10 to 15 years, it's harder. I actually have friends who have quit practicing because it's so much harder than it used to be. Used to be able to adjust these kids and they would get well. And now you adjust them, of course they get better, but now they need so much other support at the same time, whether it be nutrition or functional support, like what you do in your programs. Yeah, it is much worse. And even the last 2 years now, like the repercussions of getting over the whole COVID issue. I mean, any kid who was anywhere, either on the spectrum, any ADHD, any particular issue, that has blossomed. Children's Hospital in Boston had to hire back 700 nurses because they were having so many kids coming in with suicidal tendencies, aggressive behavior patterns, and they have, once a kid is reported that way, they have to go to the hospital and they have to be monitored for 24 hours, and they needed nurses to be there. So they hired 700 nurses to deal with it. So the answer to your question is, it's really scary out there because of what's happening. And this is the kind of stuff that we need to really, take hold of.
Yeah, that's interesting. I always say, whenever I'm lecturing, I always ask if there's any educators in the room, and then educators who've been in it over 20 years. And it doesn't matter what type of health paradigm they live in. Right. They will tell you it's very different than it was before. Yeah. And one thing I've noticed in our practice, because we've always been in this genre of working with pediatrics, but then pediatrics with deflected development, which we're going to talk about here in a minute. But I've noticed a lot more severity since 2020, but the age group that I've noticed a lot more of a challenge with is the adolescents.
Teenagers.
Yeah. And so we have to understand more about what does embedded deflected development look like? And then what do we do to support them?
Well, you also have to remember that when they hit around 9, the androgens start to come in. So if they already have deflective development issues or challenges, once the hormonal system starts to come in, anybody whose hormonal system comes in, it becomes confusing to you. Now you have kids, you're right. So that is another internal stress. You have all the external stresses. That's a huge internal stress that, again, will show the weaknesses. It'll show those where their compensatory patterns are. They'll start to show up, especially when those 9, 10, 11, and then early teens. It'll really show up a lot. Yep.
Yeah. And in our approach with leading with the brain, we always say there's kind of these hot spots of really important timelines in development that's way beyond the milestone conversation, as you talk about as well. And that birth being one, around that 18 to 24 months being another, kindergarten being another, 3rd, 4th grade being another, and then adolescence being another, where it's hey, if you're people always say, I hear a lot of doctors say, not as much anymore, but a lot of chiropractors saying I want a pediatric practice or a family practice, but I don't want to work with kids with behavioral learning socialization challenges necessarily, because that's just too much. And my answer is always first of all, you need to know more about development to be able to support healthy development and know how to watch and support during these times so that we can kind of deal with something when it's like a little flame, like a little ember that's smoldering, as opposed to a big forest fire that already is like really embedded and down the road. And I say, hey, if you work with kids and families now, I don't care who you are or what you say, you are actually working with kids that are having deflected learning and behavioral socialization challenges.
Well, that's, I mean, you're right. That's like saying, I want to work with adult population, but I don't want to work with anybody with low back pain. Like they all have some issues, it's like, oh, they came in because their neck hurts, but they didn't have any, it's like, you're right. You have to be able, I mean, it's part of our job, I think, is to be able to determine their neurological health, their neurological baseline. And you may not want to, quote, treat it, but you need to have a baseline that you're understanding, because when a parent comes into and they're handing this child to you and they're saying, look, I need help with my child, and you don't have a baseline, a way to see if that baseline is changing, how are you going to take care of that kid? So you need to see, And the thing you talked about, which I thought was really great, is right. You see all these benchmarks, and these all benchmarks are based on neurological developmental underpinnings. It's also, we should be able to track, like, oh, so look, this was at age 6, this started, now Johnny, is beating up his brother who, he's now 10 years old, and he's beating the crap out of his brother. You go, wow, well, what glitch happened at age 5 or 6 that he wasn't integrating his system and wasn't until he was able to express himself, and now he's having violent tendencies, So you're right. Those are all neurological glitches that occur during developmental milestones.
Right. And so Doc, for those of us, we have a lot of, like I said, we have kind of both camps. We have a lot of people who've taken your courses and have studied under you for a long time. And then we have a lot of people who've taken a lot of our courses, and some have done both. But for somebody who hasn't done any of your courses, or maybe just the ICPA stuff, which is great. But I remember taking your course in the ICPA, and I was like, who is this guy and how does he know all this information? And I've got to take this course like 3 more times. So where would be a good place to start? And are there any like top couple things that you're like, you've got to learn these top 3 things first, or you need to lean into learning these three things first?
The deal is that the pediatric, I mean, if you're talking about pediatrics, then we have two options for pediatrics. We have the 10-month online program, which is a complete spinal and cranial adjusting. But if that seems like a lot, because it is a lot, as you know, it's a lot of work.
Yeah, we're doing that right now. Yeah,
I know. And as well, then we're teaching our hands-on seminars. So they're broken up into 3 16-hour seminars. One is spinal, one is cranial, and the other is kind of integrates the two and deals with some common challenges. So if you want to get your feet wet, then I would highly suggest to take the spinal hands-on seminar. There's going to be one in Florida and one in Colorado this year. If you're an online learner, I think the 10-month program is great, but it's not a get your feet wet. It's kind of jump into the water. We have some basic cranial. If that's something you want to add to your practice, then you can take the introduction to cranial class. That gives you an introduction to cranial work that works for both pediatrics and for adults. And we're adding 2 more classes, short ones, Atlas axis Dura restriction class and a sphenobasal class. So we're going to give you little tidbits. If you go to the peak potential program, you'll see those. If you want to jump into pediatric program, either one of the certification programs good. If you want to get an idea what cranial work is like and can add to your practice, then I would say do introduction to cranial.
And are all 3 of those programs in your Kajabi?
Everything is on our Kajabi, right? Everything. You just put in peakpotentialprogram.com, it'll pop up our courses, and it'll show all our online courses. It'll show you my books, and it'll also show you the hands-on courses. Pretty much everything we have to offer is on that site.
Great. And the Focus Doctors, that it looks like that is the page that you set up for Focus Doctors.
Yes, we did.
I'm sure that's open to anybody here. That's there's some discounts that Dr. Marty.
We have a Focus page for those of you in Focus. Amy can get you that. We can give you that information as well. And if you're on here, if we get you, matter of fact, if we get the email list from here, we can actually offer that to all the people on this class.
Yes,
we can hook them up to that Focus page.
Yes, let's do that. Perfect. Okay. Love it. Okay. Does anybody else have any questions before we jump into my portion of this class? And or Bree, I see you. Do you have anything you need to say here?
Nope, I just dropped that link in the chat for Dr. Rosen's programs. So the Focus Academy page that he created for us. So if you want to check out the chat, it's in there.
That's great. Thank you.
Excellent. Thank you so much. Anybody? Can't see all your faces, so I'm going to assume you're going to unmute yourself. Did I hear someone? Nope. Okay. All right. So my turn.
All right.
I'm going to share my screen and try to find, I've always got a few PowerPoint presentations going at one time, or keynotes. So let me find which one is the right one. Oh, these are a fun one. This Watch and Wonder one's fun. We'll get that another day. Okay. So we have a lot of focus doctors on here. We're about half and half. We have focus doctors and we have other doctors who a lot of you I've never met. I've never seen your faces before. So good to virtually meet you. If you've never heard me speak before, then you're going to see that I like to find simplicity on the far side of complexity. I love complexity. I actually think that I like spending most of my time in complexity and thinking and researching and learning. However, I'm also very practical and very systems driven. I think that in order to translate everything that we know into something that can help people see how we can help them, and that we can have protocols and systems and checks and balances in our practices to be able to get the results clinically, and also get the results in a business sense, because you're no good if you have all the information, but you cannot bridge that gap to your communities and have systems and a business setting and clinical approaches and communication and all of that work for them. It doesn't really matter, because you're not going to get to help very many people. So that's one thing. I think it might be my superpower, or we all have, like, and I joke about my history, but we all have things like our childhood trauma has given us gifts, right? We can either go like, let me hone that gift, or let me say it was be upset with the trauma. But I was raised in a very intellectual family because of the challenges that my brother had. My dad became a neurooptometrist, and he taught us about neurology at a really young age. And so we learned about, my brother and I, and mostly me, because he was the active patient, learned about development and the brain and typical and deflected neurology. And I knew nothing about chiropractic. Chiropractic was not even on our radar. I wish that it was, but it was not. And, the sad thing looking back is that there actually was a pretty close friend of my family that was a chiropractor. And I myself was a colicky baby and had tons of ear infections and was sick all the time and had my tonsils out and all these things, right? I had almost died when I was like 1 year old. And, there were all of these things. And a good family friend, I've come to find out, was actually a chiropractor. And the chiropractor said to my parents one time, nothing about my brother's developmental challenges or learning challenges. He was never checked until he had a high school back injury. And that chiropractor still didn't talk about his other challenges, just his back pain, did not bridge the gap. And this was a very principled philosophical chiropractor, but didn't know how to bridge the gap for my brother and for my family about how, altered neurological function could be impacting the way that he was engaging and learning and connecting in his world. But instead it stayed just in the back pain because of his football injury. And for me, this family friend that was a chiropractor did say to my parents, I literally found this out just like this year, said to my parents, like, hey, you should let me check that colicky baby, me, the colicky baby. And my mom said, yeah, I did. I let the guy check you, but it didn't help. And he adjusted you 2 times when you were a baby, and it didn't help. And that was it. That was the whole story. But obviously that chiropractor knew enough to say hey, I know that this would be a good thing for this baby, but there was no, and again, I was in a very intellectual family, right? And there was no communicating how it all relates and why checking me or my brother would be important to support healthy development beyond the symptom of colic or my brother's stomach issues or back pain or anxiety or whatever. And so I'm very, very passionate about helping chiropractors Learn to lead with the brain and take a whole person approach, a whole to part approach to working with kids and any age. This information really does apply to any age. But we have to be able to get out of this big, I call it the chiropractic dilemma. We have to be able to shift out of this chasing deficits. We're pretty good at it with, as principled chiropractors, which I think probably most people or everybody, I'm sure on this call is a pretty principled chiropractor. We speak subluxation. We say, we may all be kind of like in different places with that, but we all can agree that altered neurological function or altered structure can impact neurological function, which can impact the whole person. Okay, but we have to, in like adult population, or when it comes to musculoskeletal challenges, we're pretty good at saying in general, hey, that back pain, that headache, that neck pain is there for a reason, right? We're not treating that, but it is a window into something else happening. And so what I do is I look for this other thing, this other primary thing, foundational thing called a subluxation. If a subluxation is there, it can create other challenges down the road or secondary as results. And so while we're not treating your back pain, we're looking for this, we're analyzing and correcting this subluxation that's causing altered alignment and movement, and therefore altering the way the brain is receiving, processing, and sending information because the spinal cord or the nerves are down under there. However you're communicating that, we're pretty good at moving from the musculoskeletal symptom secondary condition to a principled subluxation based approach. Not always, but pretty good when it comes to musculoskeletal stuff. But when it comes to pediatrics, I find that we're really missing the boat oftentimes, not because we don't want to do better, but because we don't necessarily have the language or the understanding or the interpretation of the science and how to put it all together. And so what happens is we say things like, we don't treat autism. We don't treat sensory integration challenges. We don't treat colic or ear infections. But what we do is we look for this primary thing, the subluxation, and it can be impacting that. And we don't fill in the whole picture for the parent or for ourselves. And we start working. And if, let's say, that hyperactivity or that diagnosis of autism or the traits that come with autism that an individual is exhibiting has a diagnosis of autism, when those maybe don't change or do change, but other things come up, we don't know how to interpret that. And so we start chasing the symptom. We start losing the understanding of what subluxation and altered neurological function does as a foundation and how it impacts this individual, this child, or this person that's moving through development. And we start going, well, I don't know, let's try this supplement, or let's try this neuro rehab, or let's try this reflex integration exercise. And we do it in let me shift over here and try to use things, to try to throw things that might be really good and important approaches and clinical tools when used appropriately at the right time. We start to use those in a way that is treating and trying to cover and treat the symptom, as opposed to understanding when to use them, how to communicate them, and how to stay principled and keep chiropractic and correcting subluxation at the foundation. And I think that by finding simplicity on the far side of complexity and learning to lead with the brain by understanding a little more about development, like Dr. Marty was talking about, we have to understand more about development, the consequences of subluxation on the developing brain, and then we can fill in that picture and stop shifting to the deficit mode and treating symptoms, which of course gets us better results, which of course gets us better at communicating what we do, and it gets us a seat at the table, right? It gets us a seat to collaborate with others, not by changing what we do or trying to be something that we're not, but by making the case for chiropractic, which is what we absolutely need right now. And we have a population that is, as we had just previously talked about, that is exploding with deflected processing challenges, behavior, mental health, learning, socialization challenges like we've never seen before. And we have these families that are living in this hopeless state of, they don't know what the heck to do. Providers don't know what to do. And there's long wait lists, and we're not getting the same results that they were before. And parents are willing to look at other options. But We cannot continue to say the same old thing and not be able to completely communicate what we do. We have to be able to lead with the brain, make the case for what we do, complete the whole picture, and then we get to really be the foundation of the team for these kids. And focus doctors on here, you know this because you're doing it. When you explain chiropractic by starting with the developmental hierarchies of the brain and talking about what subluxation does and how that drives deflection in brain development, people listen in a different way than if we start with chiropractic and subluxation and try to somehow piece it together. So that's what we're here to talk about today. Now, Dr. Marty was talking about, and we were in the handoff here, talking about just kind of some of the statistics that we're seeing. And I want to make sure focus doctors on here, I know you are familiar with these statistics, but I want to make sure everybody is familiar with these statistics. And now remember, when we're talking statistics, these are old, right? It takes a while. It takes a year, sometimes multiple, sometimes 3 years to actually get statistics. So we're not even looking at really the statistics of these things we're about to talk about that are happening right now, right? It takes a long time. So when we look at this globally, 7.2% of children aged 18 and under have ADHD, 9.4 in America. I'm doing a lot of research in other international places because, globally, because we're teaching this stuff in different places now. And where typically the United States is leading the way with these statistics, which real great on that. But a lot of countries are actually right there with us. And it's pretty darn disturbing. And so you guys can read this. I'm not going to read these to you. And also, if anybody wants these slides, I had a couple people email and ask about that. I'm definitely willing to share these. I'm sure Dr. Marty is as well, but we can give these to you. So look at this. Now, autism reported in 2021. See, here's this from 2018. Now imagine what that's really going to be in a couple years. And this is 1 in 44. We've actually seen, I think it's 1 in 36. Is it from other? I can't see the chat on here. So if somebody wants to say something, I see there's like some activity in there. But if you want to say something, you can just unmute yourself and interrupt me. I don't mind. But there's other statistics that say 1 in, I think it's 36. Is that right, Bree? 1 in 36, or maybe even 1 in 31 now. I can't remember. There's different stats that are coming from different places, and they're very heated. People get real heated talking about this and talking about, is there really an increase in neurodevelopmental disorders? And this was even before 2020. Is there really an increase in autism? Is there really actually an increase in neurodevelopmental disorders? Or are we just diagnosing it differently? And so let's just talk about that for a second. And first of all, that was even before 2020. And now we're looking at things even definitely like collectively, we're looking at things differently and more. The statistics and the increase in prevalence of behavioral learning socialization challenges is more accepted across professions now. But when we look at this, I mean, we just have to go, of course, there is some increase in the statistic because of the way we're diagnosing and because of how the categories of diagnosing happens. Yes, of course there is. Of course there's some, there's someone who needs in there, Bree. Of course there's some increase in diagnosing because more people are actually getting, having assessments done and more, and we're better at diagnosing supposedly. And so of course some of those factors are there, but it doesn't account for the massive increase that we've seen across all neurodevelopmental disorders. And when we look at what's happening even now and through the pandemic, I mean, there's just tons and tons of research coming out, research and opinion from other, from different medical professions saying, hey, wow, a pandemic and having kids not socialized and having kids living with the chronic stress of their parents in the home because of the isolation and because of the fear and because of the financial concerns, literally looking at the increase in behavioral learning, socialization, and early life developmental IQ, and how that is decreasing. We're seeing a 22 point in this study that went on to be published, and it's from Brown University, looking at how when we look at kids that were born during the pandemic, not to mothers who actually contracted COVID, but they did not contract COVID, so that variable is out. They were looking at what was their developmental IQ, and we saw, compared to previous cohorts, 22 points lower. So we're seeing that it is accepted, kids and adults, when we look at mental health statistics, when we look at executive function, when we look at stress response, stress, not just of the child, but stress of the home, stress of the parent, of any age child, stress in the family is impacting the way the whole family engages and learns and connects and adapts. And of course, we as chiropractors, we know that this is a good time to be a chiropractor. I'm telling you. Dr. Marty was talking about how, some of his colleagues are like, hey, this is overwhelming. I wanted to get out of this because we're not seeing the same results that we were seeing before. You correct subluxation and that snowball starts rolling downhill and people get better quicker, faster and more robust, changes, as opposed to now. Well, now we have so many stressors. And one of the big things, and we're going to talk about this when we do the hierarchy. I might even do some whiteboarding over here. Focus doctors, you can laugh at that because you know what that means. But when we look at the increase in demand socially and academically on kids, when we have a decrease in developmental readiness, we are more slowly developing, with more gaps and more deflections, not as efficient tools to meet the demand of our social, movement, sensory, academic world. But yet, what we do is we push academic demand younger. So we've got a big, big problem. Now, as chiropractors, we have to be able to, one, learn to make the case, of course. We need to do that by respecting the whole person. So again, we don't shift to that chasing symptoms deficit mode. We keep chiropractic the foundation, correcting subluxation the foundation, because it has to be. And we need to also be able to understand the neurology of the parent, and the parent in chronic stress, and the parent specifically when we're talking about kids that are already exhibiting behavioral and learning and socialization challenges. We have to know how to communicate with them. We need to know how to create a safe place, like physically and procedurally and system-wise in our offices for them. Because if we do not do that, we do not get to open the door to help their kids. One of the things I hear a lot, or I have heard a lot from new doctors coming into this work, is I don't know if I want to work with that population of kids who are having, learning challenges or behavioral challenges because the parent, or autism, because the parents are so hard to work with. I hear that a lot. And I say, well, you might just not be understanding their neurology and considering what it is to be living, what it is like, and how it impacts that parent's learning and decision making and follow through. You might not be considering what's happening to them and how they learn, and how you need to have systems that are set up to meet them where they are, not change your recommendations, not shorten your care plans if you have a certain amount of care plan. I'm not saying that. I'm saying you need to know how to educate these parents, how to connect with them, how to communicate with them to make a place that works for them. Then they're not so difficult to work with. It's like if you're trying to connect with a child who is 2 and you're trying to communicate with them in a way that requires massive executive function and they're not there yet. Well, there's going to be frustration, and you're going to feel like that child is having avoidance or behaviors, or they're difficult to work with. I'm not saying that these parents are there, but we have to understand it has nothing to do with intellect or intelligence. It has everything to do with stress, chronic stress, and how that's impacting the neurology of the caretaker or the decision maker. Now, in order to start to find the simplicity on the far side of complexity and start to respect these concepts of, leading with the brain, developing a whole to part person approach, and then doing this clinically in your office and having the right, and specific adjusting protocols, of course. And that's why I like supporting what Dr. Marty's doing and learning that, because we have to be very good at correcting subluxation, of course. But in order to do that, we first need to have a kind of a bigger picture understanding. And I like to, again, find the simplicity. And so we're going to do that in this discussion today. Some of you will recognize this, but through the two brain-based concepts, right? We're going to start with the first brain-based concept, and this is going to help us start to develop our brain-based lens, right? Our 30,000 foot view lens of, how does this all fit together? What is our place even in this? I want to discuss also a little bit about subluxation and some visual system implications of subluxation and some things I've struggled with in my understanding of chiropractic as well. I'm gonna share that with you and give you a little insight into my brain and my thinking, and then we'll go into further understanding development and some things to include on an exam in our second brain-based concept. But in the first one, I want to just talk to you about this. Now, focus doctors, this is what we refer to as the triangle of simplicity. Right here, if this is literally all you get, doctors, new doctors to our world here, if this is all you get from this presentation, this is a win, because this seems simple because it's simplicity on the far side of complexity. But this concept of the triangle of simplicity will allow you to start making the case for chiropractic to providers, to other providers, to lay people, to your patients that you're already seeing in table talk, and be able to do it in a way that keeps you congruent with chiropractic philosophy and keeping chiropractic at the foundation and not treating symptoms. And it just goes like this. It's the whole concept of, listen, and again, it can be used for all ages, but it's just this. Listen, why do we see kids? Why is it important that a child be checked and adjusted for subluxation? Why? Who cares? Especially if they're not symptomatic, right? And so the reality of that is just, listen, let's just look at what we know. What we know. And when I say what we know, I'm not talking about what we know in chiropractic. I'm talking about, what do we agree on when we take a look outside of chiropractic? When we look at, what other providers, OTs, educators, speech pathologists, medical doctors, psychologists, what do we all agree on? And here's some things that we all agree on. Like when I just peek outside of chiropractic, I go, listen, well, here's some things we know. We know that the brain is not fully developed at birth. We know we have to move through a trajectory of development. We know that, again, finding simplicity on the far side of complexity, we know, Dr. Marty just talked to us about it, that the brain starts more primitive and becomes more sophisticated. We kind of develop in this bottom up, back to front, inside out, right to left kind of way. I like to say, because we want to give people imagery, right? Imagery is important for learning. And retention and comprehension, which we'll talk about. But we know the brain is not fully developed at birth. Everybody here at this pretend table I have of OT, speech therapists, medical doctors, we're all sitting around a table. Why would a kid need to be adjusted? Well, hey, what we know is the brain's not fully developed at birth. We know the brain has to move through a trajectory of development, and we know that different things influence that. Right? We know that the way, that sensory information is being received and experienced for that child, like if there's alterations in light and touch and sound and food and movement, all of these things, we know if they're altered, that can impact the way the brain moves through that bottom up, back to front, inside out, opening up like a flower, the way that brain opens up like a flower. If we alter input, it can alter growth. We know that. Everybody agrees on that. We also know that stress has been shown, stress of all different types, physical, chemical, emotional stress, has been very well documented and continues to be documented. And this is an area that's just exploding in these post-pandemic times, where people are really across multiple different professions, really looking at stress, physical, chemical, emotional, preconception, all these different stresses, and how that stressors can impact the way the brain moves through development. So we know the brain's not fully developed. We know that stress can impact that, the way the brain moves through development. And here's the kicker. All you people around the table that are looking at me, the chiropractor, asking why chiropractic, we say, listen, it's not just that stress, being in the vicinity of stress, being in the room of stress is the thing that causes the impact on brain development. It is the changes, the manifested changes that happen neurophysiologically, neurometabolically inside the brain and the body as a result of stress, the adaptations, the changes that happen as a result of stress that impact the developing brain. We know that, right? We understand that. Well, listen, one of those big things the thing that we look for is called a subluxation, right? Subluxation is one of those things that can happen as a result of too much physical, chemical, emotional stress, unable to adapt. We can see a shift. We can see, I like to talk about gut breakdown here as well, but subluxation and gut breakdown or dysbiosis or alterations, and that, the presence of that, which is what we look for. We specialize in that, looking at this manifested change as a result of stress. And when that's there, that is what can impact the way the brain receives information, processes, and sends. And now we're going to talk about that here in a little bit in the next slide, actually. So this is a very simple way, and that was even a longer way. I would do that in 1 minute. And I have many times, and all of you focus doctors have many times, use this triangle of simplicity to explain why do kids need to be adjusted, right? Why do they need to be checked and adjusted if necessary to maintain a clear and functioning input, processing, output system? Because that altered input alters growth. Now, that is something that when we can communicate it that way and understand it that way, and then we can start to build our systems upon this understanding, this very basic first brain-based concept, it will change your practice. It will change the way you communicate. It will change the way it will stop you from shifting to this deficit. It will start giving you this 30,000-foot view and enable you to maintain this pediatric and whole life practice of looking at how does subluxation impact the brain, the developing brain and the processing brain in all life. Now, one of the things that I struggled with, and when I came to chiropractic, right, I told you I was not born in a chiropractic family. I did not grow up with the chiropractic paradigm. We were a neurooptometric family. That's what we were, right? That's what my dad was. That's what we learned about. And that's how we saw the world. I wanted to become a chiropractor to help people with back pain. And some of you, because we've got East Coasters and Midwesterners in here, and actually, Dr. Marty, you might actually know this person too. When I decided I was going to be a chiropractor, I was going to Michigan State at the time, and I said, okay, well, I've never been adjusted. Come to find out I had when I was an infant, but I didn't know that. So I'd never been adjusted, and I decided I needed to go learn about chiropractic. So I went around to all these chiropractic offices, and I was wanting to be a CA or volunteer or something, because I was like, I need to get adjusted and I need to learn about chiropractic. So I did this, and about 30 people turned me down, which I thought was crazy, but I kept going. And this one lady, Dr. Linda Rassel, she hired me. She actually offered me a job, which I was like, that's amazing. And she started teaching me, and she was teaching me about innate intelligence and subluxation. And I had no idea that that's what chiropractic was about, but I started to kind of connect the dots. And I was like, this is interesting. This is kind of like the things that I've learned about in neurooptometry, but they're saying it differently. Then I went to Sherman, and I'm learning about, neurology, and I'm learning about subluxation and philosophy. And I'm like, wait a minute, these things need to go together, which has led me on this path to collaborating and putting this stuff together. But the thing that I really understood, it made sense to me right away, was that physical stressors, this whole concept of physical, chemical, and emotional stressors, I was like, I can get on board with understanding that physical stressors, if a kid or an adult or somebody of any age falls down and hurts themselves, they can shift these bones maybe, and then kind of get stuck, and we can have inflammation around the joints, and then we can have this thing called subluxation. And if that's there, I understood the neurology from my neurooptometric world, and it was like, yeah, then if you have altered movement, then that's going to be altered input, afferent input, and then that's going to be a problem for the brain. And I kind of was seeing that. I was like, yeah, physical, that makes sense. Chemical, it even kind of made sense, because if we look at, it was easier for me to grasp like inflammation and stress response and autonomic nervous system. And I was like, that makes sense. But man, emotional didn't make sense to me. And I guess it certainly makes sense to me now, but I would love to see it in the chat. I'm just looking at the numbers, or raise your hand or unmute yourself or whatever. But has anybody struggled with this concept ever before in their understanding of subluxation? And I just couldn't conceptualize and understand really how emotional stress could cause this subluxation thing that seems so structural. Even though I know now we're not limited to that structure and we're not mechanists, but I really couldn't get it. And then I started thinking about the visual system, and I started thinking about what is emotional stress due to the visual system, and then how does that cascade play out? And I want to talk about that today, because I haven't heard this talked about in our profession, but I want to share this concept because it can help us understand from a pediatric perspective and a whole life perspective about the emotional stress component and how we can relate that into what we're looking at now with mental health and deflected processing. So let's just look at stress. So when we have stress, there's a lot of things that stress does to the body. We know that. There's a ton of research in that. First of all, has anybody ever had this challenge with emotion, physical, chemical, emotional, any of those being those, those 3 T's, or did everybody here just go, yep, okay, that's what causes subluxation? Did anybody question? Did anybody get stuck on, but why? And how does that happen? Anybody? I'm the only one. Maybe you guys don't want to hear this part, but I'm going to share it with you anyways. Is there one? Was there one? Oh, yes, Shay, yes. Well, you're going to like this part. You've probably heard part of this before, but so what happens to the visual system, right? To the visual system. So I was thinking about what happens in your body as a result of stress. Well, we know we have dilation of pupils, we have narrowing of the visual field, we have changes in the z-axis ability, meaning accommodation. So accommodative changes to be able to go from near to far and be able to focus at a far point, focal point, and then near point. We know we have changes in that accommodative system. We have tensing of the musculature and changes in blood flow to the extraocular muscles. We know that there is a pretty significant change in the visual system as a result of even acute stress. There's actually a lot of research on this, acute stress, but then also chronic stress, right? And so if we look at, so if we have increased stress, emotional stress, and we're not even talking about the physical or the chemical, we have increased stress leading to potentially altered. Now we have kids now and adults living in a time of massively increased stress, right? We know that as a result of that, listen, I'll tell you just the other day, in focus, we learn to look at the pupils. We talk a lot about the eyes, but I was looking at my daughter. She was acting fine. She was seeming fine. And I was looking at her eyes the other day, and her pupils were not reacting typically. She had more dilation. She had more tension like this. And my husband and I were looking at her, and we were like, let's go get her adjusted before bed. Let's check her and get her adjusted and make sure we're doing the things to support her. And we did that because we saw that these eyes were a window into her autonomic nervous system, and she was experiencing responses to increased stress. She had more pupillary dilation, and I could see her having convergence and accommodation issues just in her playing with me. And so this was a big window. I was saying, increased stress, altered visual function, altered visual field, tense and postural changes. Well, what does this do? Let's now go from stress to vision to posture, right? I'm having z-axis changes, accommodative system changes. I'm having altered posture. Let's say it becomes chronic. because we didn't develop our visual system well, because we're talking pediatrics here. And now we have altered posture, or we have kids that are like this all day and they have altered posture leading to increased mechanoreception. I gotta move this thing. Hold on a second. I had to move you guys over to a different part of my screen. Am I still sharing my screen? I am? Okay, great. So hold on. I can't, there you go. So I just moved it right back to where it was. That's okay. So we have increased stress, we have the altered visual, we have visual system changes, we have altered posture, mechanoreception. If we have that, now we can agree that we went from a stress scenario to an emotional stress scenario that got us to subluxation. If we have subluxation, then what happens? Then how do we go from subluxation to brain development? Now, Dr. Marty talked about this a little bit, but if we have, even for people out there, and I know that's not this group, but I always like to say this, like, listen, we can have the most musculoskeletal symptom-based chiropractor or PT or whatever, and we can have this conversation. We can go, listen, do you agree that oftentimes when there is altered posture, let's say, or a back pain or headaches, that one of the things most chiropractors are going to say, or PTs, is they're going to look for tone changes. They're going to look for range of motion changes. They're going to look at that globally, and they're going to look at that somewhat segmentally, maybe not as specific as we would, but they're going to look at that. They're going to look at that at different regions of the spine and the body. Now, they're going to say, hey, if you're having back pain, for example, or postural tonal issues or whatever, at any age, if that's there, we can agree that we should look at the structure below the musculature, and we should look at the movement of the body, and we should look at the movement of the joints. And if we have altered movement, right, and we have fixation, right, let's say segmental joint dysfunction, if we have that, we can agree that there is going to be altered afferent input in some form, because we have altered tone, altered movement, we have fixation, or we have changes in the way that the spine or the joints in the spine are moving. If we have altered input, altered mechanoreception, altered proprioception, if that is the case in a child that is still developing, now we have altered input coming in through a massive part of the sensory system. You know, just like if we had altered vision or altered auditory input, or altered, light, we need to have congruent input coming in this way through our mechanoreceptors that are matching what we see our body is doing, what we feel our body is doing. And if we have alteration or a disconnect in that, then we know that we're going to start to begin to have altered development of the brain and knowing where my body is in space and how to move it. So we can go from, hey, stuck joints, tonal issues, muscular aberrant or abnormal asymmetrical changes with the musculature around the spine or in the body. And we can take that to a neurological conversation about, if that becomes chronic, then we can see changes in the way the brain is receiving information. And if we have altered input, we know, everybody knows in the brain development field, that if we have chronic, or if we have altered inputs coming in through a sensory system at a time when the brain needs that input, it's going to alter the way the brain moves through development. Just like Dr. Marty was talking about, if we have too much or too little input to the cerebellum, that's going to impact that bottom-up development, and later down the road impact the way we're using our prefrontal cortex, and or potentially causing overactivation in our limbic system, our midbrain, and decrease activity or function in our frontal areas. Now, so we're going to go into the third part of this triangle, which is, what is that actually, who cares? Like, what does the altered brain development, if we have altered input from subluxation, let's say, what does that actually do to brain development? And in this conversation, and this is going to be a quiz question, so this is important just as a precursor to what we're going to talk about here. When we're talking about vision, which is a big part of this work, we really need to talk about 3 different types of vision. Okay. So most people, when they think of, even in our profession, when we think of vision, we're thinking of things like visual acuity, which is, 20/20 vision. Are there any refractive errors? How's the light hitting the retina? Do I need lenses, corrective lenses, not like prisms, but like lenses for reading, nearsighted, farsighted, that kind of stuff? That's typically where the conversation ends. Even, this is tricky, but even when your patients or yourself have said, I've been to an optometrist and they said my vision was fine, a typical optometrist is really just looking at visual acuity. That's what they're looking at. They're maybe looking for gross misalignments in functional or dynamic vision, which is the third part we'll talk about, or the third type of vision. But typically, they're really like, if there's a strabismus or amblyopia, but like a misalignment of the eyes, or like a lazy eye, intermittent or ongoing. But really, they're typically looking at visual acuity. Then we have, well, actually, we'll talk about this as the second part of vision, is this functional or dynamic vision, which is like fixation is, we're looking at a target here. We're able to have fuse to one target, to where we have monocular vision, where I'm not seeing 2 pens here, I'm seeing 1. And then tracking, now I can track that target, right? And then convergence and divergence. Divergence isn't talked about quite as much, even in neurooptometric circles, but it is very important. So being able to go from a near target, a near focus, to a far focus or to a far target, and looking at any segmentation or any challenges in the way that the eyes are moving, and then vice versa, coming in and convergence. So this is more of that functional or dynamic vision. And that's very important, especially when we're talking about childhood development and behavior and sensory integration and learning where my body is in space, and definitely academics and socialization for sure. Then we have mind sight, right? And this is like where we are using visual imagery, our mind's eye. We can recall images, we can create images in our mind, we can recall, memories in visual form. We can think about the future because we're thinking about vision. We can understand the organization of our closet by looking at it. This is really the seat of executive function, this mind sight, this ability to use our visual imagery to guide us as humans. And this is really our kind of gift as humans, right? Is this mind sight, this ability to do this. And so this is an important part of the whole developmental process, is being able to go, is visual acuity good? What's happening with functional and dynamic vision? And do we have mind sight development? And this is where we're going to start putting these pieces together. Now, here's just some studies. Again, I said we could share this if anybody's interested. Just put it in the comments. You want these? Put in your chat right now that you want, if you want to see these slides, you want to have them for reference. This is just some studies looking at mental stress and intraocular pressure and changes in the visual field as a result of stress, which you'll start to be able to put pieces together here. Okay, if some people want these, we'll send them to you guys. to 2 people. I'm just kidding. We'll send them to all of you if you want them. Head posture and autonomic nervous system and sensory motor control. Listen, those of you who've ever been in any of my classes know I really like to find the research to validate what it is we're looking at. Look at this. Participants with forward head posture, structural changes exhibited abnormal sensory motor control and autonomic nervous system dysfunction compared to normal head alignment. Evaluation of cervical position sensing forward head posture. So basically, when we have an individual with more forward head posture, if we have them close their eyes and do a repositioning, now reposition my head back to neutral, we saw individuals, so my ability to close my eyes, visualize, use my mind sight, which of course is created, my visual imagery of where my body is in space and moving my body is in space, is set. Those neurological underpinnings are set based on input, driving growth, driving my visual perception of myself and outside of myself, all set in early life. So individuals with more forward head posture, alterations in structure, altering neurological function, when they closed their eyes and they did this head position repositioning task, they found that individuals with forward head posture had more of a difficult time being accurate on that task as opposed to those without. Structure impacts function, impacts development, impacts perception. Altered perception impacts mental health and the way we learn and connect at every single age. Here's another one, structure, function. This is a great one. I'm going to keep moving, but we have these for you. We'll send them to you. Proprioceptive input from the neck muscles appears to influence the extension of neglected part of space in patients with neglect. All this means, you guys can read this. This is a great one. This study has been done over and over and over again. This one's old, but it's been done and done and done. And this is just looking at literally what's going on in my neck and proprioception, my proprioceptive awareness because of what's going on here and alterations here, impacts the way I visualize space and my body in space. I see Bree that you're trying to get in it. Are we good?
Yeah, we're fine. I'm just having computer setting issues. So I'm going to post the next question in just a minute here in the chat.
Okay, cool. So I don't know if I answered all the questions yet though. So just make sure that I did that before or wait. So sensory motor disturbances in neck disorders, postural stability, head and eye movement. Listen, when people, now we have a whole research branch in the Focus Academy. Dr. Sarah Hawk is on here and she's my research partner. We just put out a research paper, but we also have a lot coming, and Focus doctors, you're involved in that. And we need to be able to research in a congruent way with what chiropractic is really about. And that's what we're about here in the Focus Academy. But we also need to be able to know how to consume research that's not chiropractic research. We need to, with this lens, we can look outside of chiropractic and say, what does this mean? And how does this make the case for what we do? And how can we learn? So this is the most fun part. When we look at this triangle of simplicity, we say, listen, the brain's not fully developed at birth. It has to move through this trajectory of development. There are things that impact that. Physical, chemical, and emotional stress are very well documented in many, many places, in tons and tons of research for many, many years, to impact changes that happen inside the brain and the body as a result of the stress that actually impacts brain development. We've determined that we can have hours and hours and weeks that's starting to tie these out, but we have this peg, we have this simplicity, and we can dig in. Is my internet connection good? I just got a little thing. Okay.
You're breaking up here and there.
Have I been the whole time, or are we good?
No, just like in the last handful of sentences.
Okay. But it's good because my thing went away. It says I'm good now. So, okay. So now let's talk about what does that altered input actually do to development? So let's just talk about, this is what we call in Focus, doctors, some of you know, that we have these 8 hierarchies of development, right? And so again, finding simplicity on the far side of complexity, we have to start by putting these pieces together. So let's zoom in now on development. Let's zoom in on what are some things that we look for and some important concepts in understanding this whole bottom up, back to front, inside out, right to left, that brain developing like a flower. If we're saying we know that, subluxation and other influence that can alter input, which can alter growth, let's look at what altered growth can actually look like and go from there. So when we look at early life, and Dr. Rosen talked about this a little bit, but we look at what some of our primary tools are. I'm taking that one away because we're going to do it on the whiteboard. You can tell me if you can see the whiteboard when I start drawing, how about? But when we look at early life, and we look at what the primary tools that we use, that a baby uses in utero and in the beginning of life, we want to understand that that's kind of the tools that we use are windows into where we are in development. So as the brain moves through development, we gain more sophisticated tools at each stages of development, right? As we go through that brain blossoming, right? We know that we gain different tools when we have those different tools. Those are the tools that an individual is going to use to connect and learn and engage in their world. Those are going to be the tools that we observe. So the behavior is giving us a window into what tools a child or adult is using primarily. Of course, it's not only one tool, but their primary tool. And that gives us an indicator of where they might be in development, or where they may have some deflected development or some embedded, like Dr. Rosen was talking about, some patterns of were developed early on. And that starts to change the conversation from shutting down a symptom to understanding a symptom or a observable challenge or behavior. So in early life, like the beginning of life, first year and really like first months, and they integrate at different times. We know the primary tool of processing is our primitive reflexes, right? Or infantile movement reflexes. And we know that can you see this? Okay. Did we break up, Bree?
No, I see some heads shaking no, and some shaking yes.
Okay, I'm going to show you this one too, and I'm also going to show it here. So don't worry about it. These say the same thing: primitive reflex, infantile movement reflexes. So listen, as we become more sophisticated, we start to develop our next primary tool. Those reflexes we start to have inhibition in that first year of life at different times. But the big picture is we're starting to become more coordinated in the way that we're moving our body with our big muscles first, and stability and core and trunk. And we're starting to, see a baby able to hold their head up and able to sit up and roll and cruise, and all of these things are starting to happen. And we know we're moving through development, we're gaining more sophistication in our movement touch systems, right? And so we're starting to use our movement touch systems, movement tactile, to primarily process the world. Of course, this is broken up, and we've got gross motor first and fine motor. And here we've got a bunch of these different reflexes, right, in that first year of life. And we know that the primary tool at that movement touch time, if a child is there, that's when they need to move their bodies. They're touching things, they're putting things in their mouth, they're moving their body. It's a problem when we take a case history. Those of you guys have done this. You take a case history on a kid that's coming to you, and they're a teenager, and they have mental health challenges, they have anxiety, or maybe they're a deep diver and they're super far ahead in reading, but they have massive anxiety, trouble socializing, they're cutting, things like this are happening. And you talk to them, and the parents like, I don't know what happened. They were the easiest baby. You're taking a history, you're getting more information about early life. And it's really, this isn't always the case, but this is a presentation that is very common. Yeah, they never moved. They never I didn't have to baby proof my house. I didn't have to like watch them. They never put anything in their mouth. You just put them there and they would stay there. They were so happy. And you should be thinking, okay, so we know that in that first year, we want to be developing this gross motor and fine motor and vestibular and moving into our primary tool of movement touch, and therefore feeding that movement touch system. And if we didn't, that's a window into, the brain of, well, why weren't we engaging? Why was this child not engaging in that way? What was going on there? Right. So just little cues. Now we go into our second year of life, and the next most sophisticated tool that we start to develop in that second year of life, of course, some of it's happening before, but we start to put more of our attention into our auditory verbalization. So now these cues, these babbles, these noises that I'm hearing, I'm starting to attend to them. I'm not just attending to, touching and putting in my mouth and things like that. Now I'm attending in a more interested and sophisticated way of, hey, mom or dad first is making these noises, and I want to make them back. And that doesn't start as sophisticated expressive language, but it starts as this auditory verbal dance of like, hey, I'm more sophisticated in my tools, and I want to put more of my attentiveness into auditory verbalization. All the while we're integrating and developing and moving into more sophisticated tools to process. Then this visual system, of course, all along the visual system is starting to develop, but at that 24 months, really it's like 18 to 30 months, somewhere in there, we're really starting to have more stable, accurate, precise, and predictable eye movements about hey, I can look out there, and then I can look in here, and then I can do this. And I'm now able to say, when I start getting accurate and predictable information through my visual system, through converging and accommodation, and I'm starting to accurately predict, and learn about my environment through this information, through these eyes, through that dynamic visual system coming online, right? And function, that functional and dynamic visual system. Now I have a way more sophisticated tool than just touching and making noises. I'm going to use these things, which drives my visual perception of my body in space. But if I don't have an accurate, if something is altering the way my brain is moving through development and altering the way these fine motor skills come online and impacting the way that accommodative system happens or develops, stress, subluxation, altering proprioception to know how to actually move these eyes in an accurate and predictable and stable way. When that happens, I'm not going to put my primary seat of attention into vision. It's going to halt or change my trajectory of development, because now I'm getting contradiction between touching and noises and my visual system. And so I'm going to go back to touching and noises and different ways of processing as opposed to using my visual system. And so we have that visual motor development. And then finally, let's say we're moving through development in this very typical way, infantile. The brain is developing bottom up, back to front, center, right to left. Infantile movement reflexes are integrating. First year of life, I'm moving into movement touch. I'm becoming sophisticated in moving my body around and connecting with others and my environment in this movement way. Then auditory verbal. Now I'm getting accurate and predictable eye movements. And that's leading to my ability to visualize my body in space and how it relates to other things in space, my visual perception. And therefore, my executive function is starting to come online at about that 5 years old plus that 5 to 7. We're starting to see more of that awareness outside of self. That's what Dr. Marty was talking about. I thought it was interesting. He was talking about like, hey, this is when we learn how to engage with others and other things around us. And if we miss that, it's a problem. And I agree. And that's why at this time we use our visual cognition. So when we move through this development in this typical, not deflected way, because we have appropriate input coming in, we are not subluxated in this scenario. We have appropriate input coming in. We are driving development. We are moving through infantile movement, movement touch, auditory visual, and we're landing in that visual cognition. We are moving through this healthy trajectory of development. Now, hold on a second. I want to talk really briefly about visual cognition. So if we as humans, I mentioned this, we are visual creatures. We have this ability, our most sophisticated, our most are really like our gift that allows us to be not just impulsively reactive to our environment through more primitive tools here, is the fact that we can have this visualization, this visual representation of our own self and outside of ourself, and create and use this mind's eye, this visual imagery. Listen, I'm going to do this so quick because we don't have a ton of time, but those of you who haven't done this, focus doctors, you've all done this, but others of you haven't. So I'm going to tell you, our most sophisticated tool as humans is visual cognition. And I'm going to prove it to you. I'm going to tell you, I'm going to say something. I'm going to say something to you now, and I do not want you to visualize it. So I'm going to give you an auditory input. I'm going to give you an auditory input, and I do not want you to create imagery. I don't want you to turn it into imagery at all. I want you to not do that. Ready? I'm going to say it in 3 seconds. Do not visualize it. 1, 2, 3. Pink elephant. Okay, now focus doctors know what's up. Anybody else out there who wants to play? I don't see your faces. You have to literally unmute yourself if you're going to be brave and play. Tell me, did you or did you not visualize the pink elephant? I told you not to do it. You're all intelligent people. I told you do not visualize the pink elephant. Did anybody visualize the pink elephant? I can't see you, so you have to play. You have to be brave.
Yes.
You did,
Yeah.
Dr. Marty?
I actually, because I'm stubborn, visualized a gray elephant just so
Yes.
we did.
Beautiful. So what this guy here did, I love that. That's the next question is who didn't visualize it? And I say, okay, so you didn't. So you knew. I said, I'm going to do a demand and I want to see if you're going to do it. And what Dr. Marty did is he said, I'm not going to visualize that. I'm going to visualize something else. So I'm going to take my highest tool and I'm going to deflect from what Amy's going to tell me. And I'm going to occupy my attentiveness, but still in a very sophisticated tool. And I'm going to visualize a gray elephant, but probably as soon as that left, you probably did visualize the pink elephant because we're talking about it now. Somebody else in this room, maybe the Zoom room here that does or doesn't want to talk, maybe like said, oh, I'm just gonna like wiggle my leg, or I'm gonna like write something. I'm gonna deflect by distract myself with using movement touch. I'm going to use movement touch in my attentiveness as opposed to like attending to the auditory input and then my brain turns into this visual process. So we are visual creatures, right? Listen, if I walked into this room and we had a kid who is not there yet, something has blocked this kid. Maybe it's a subluxation, right? That's altered input, altering this trajectory here, but something has blocked this 6-year-old kid from becoming fully developed. And this 6-year-old kid's primary tools are moving their body, touching things, and making noises or language, auditory verbalization, and movement and touch. And I am fully developed, and my primary tool is visual cognition. This is for those of you who've never heard this. We walked myself, I'm fully developed. My primary tool is visual cognitive function. And so I don't need the other tools to guide my primary processing. And a kid who's 6 or 7 or 18 or 42, whatever, walks in this room, their primary tools, because of their developmental trajectory, live in movement, touch, and auditory verbal. The question is, who touches more things? Ask yourself that. Who touches more things? First of all, what is the behavior, the observable behavior of the kid whose primary tools, I know you can't see that, whose primary tools live in movement, touch, and auditory verbal? What do they look like? When they walk in your office, what do they look like? When you observe them in a classroom, what do they look like? They're moving their bodies, they're touching everything, maybe they're making noises, they're using their primary tools in a very appropriate way to engage and connect and learn from their environment. That doesn't make them bad. That is a window into where they are. It may mean that there's some deflected development going on, but it doesn't make them bad. It's not a behavior, it's a window to be understood. And so we say that kid who's moving, touching, and making noises walks into this room, you probably said he touched more things because his behavior was he went around, he touched everything in my office, and maybe licked things, maybe kicked things, maybe did all these things, and he was hyperactive and impulsive and reactive to his environment with these really primitive tools. But I walked in this room and I just touched everything with my eyes. I touched everything with my mind. I touched everything. I touched way more things than this kid did. I just did it with a more efficient tool, you see? So if we have something blocking or inhibiting, it's usually not fully blocked, right? But we have something that's impacting the way we move through development. It impacts the tools that we bring to the table. Then those tools are what we use to engage and connect and learn from our world. If we have a kid who's not there yet, this is a big focus concept, not there yet, because we know, yes, it's easier and more productive when we have this appropriate neurodevelopment and neuroplastic change early in life. However, we can create change, but it has to be very specific. We have to do one, we have to correct the underlying issues that may be there that has led to this deflected development or gaps. And two, we have to know where is a kid or an adult on these hierarchies? What are their primary tools? And then we can start doing the specific brain and body movements and things like that, in addition to correcting and maintaining a clear nervous system. But we don't do it just based on treating deficits. If we have a kid who's not there yet, and their primary tools live in movement, touch, and auditory verbal, and we give them an academic demand that is a visual demand. We introduce them to abstract symbols like reading or writing, or even math, although that's a little bit different. and we give them that, they're going to bring the tools that they have to this table. Or if we continue to press them and continue to press them, they're going to deflect and they're going to drop down in the hierarchy. They're going to become more stressed, more limbic activation, more avoidance, more socialization challenges. And those of you who've done any of this work before know that we spend about, in our certification series, about probably 10 hours on this hierarchy and the clinical assessment hierarchy. And there's just a massive amount of information to be done learning about this one hierarchy that you're looking at on your screen to understand what it is that you're seeing in these kids. It's not just that they're dysregulated. It's not just that they have this, behavior. It's that they have had interrupted developmental progress for there are a variety of reasons, and we must understand it. We don't have to correct. We don't have to treat it. We have to understand it. We have to know how to take an appropriate case history. We have to be able to look for subluxation and look for other stressors that are impacting the autonomic nervous system that may have led to this developmental trajectory change. And then we can start putting the pieces together. So there's a lot more to discuss here, a lot of things I'd like to discuss here, but this is just an introductory conversation to this concept of leading with the brain. Now, the second brain-based concept, because we're very principled in our work here in the Focus Academy. We say chiropractic subluxation correction has to be first, because we cannot, and this is the big kind of beef I have with some of the other approaches inside and outside of chiropractic, where we're just looking at, let's just do primitive reflexes, or let's just start doing brain rehab, or let's start doing auditory verbal or interactive metronome. We cannot do that until we first address why we have deflected development and then what we see on the deflected development. So what my recommendation is using, this is what we teach, using the second brain-based concept to start putting these pieces together. This is what really is the foundation of our clinical exam. One is, hey, first question, we have to ask and answer two questions on our clinical exam. The first is, are there indicators of inefficiencies or imbalances in input, processing, output, right? That's our subluxation exam, right? And two, how is this individual using their brain, right? There's someone trying to get in there, Bree. What tools are they using? What does that tell us about where they are in these this developmental trajectory? And this goes for any age. This is where we start to incorporate our functional brain-based assessment. Subluxation assessment, is subluxation there, and how's it impacting the brain, right? This is where we start to bring in infantile movement reflexes and gross motor and fine motor and eye movements and that dynamic vision and visual cognition. This is literally what we teach in our clinical exam. We must ask and answer the two questions. We must have indicators of subluxation. In my world, there must be some sort of mechanical or structural alteration, whether it's movement, whether it's posture, whether it's we're looking at the cranium, we're looking at upper circle. There must be something there, and there must be some sort of neurological component. We also look at and talk about looking at the eyes and the pupils to look for an indicator of autonomic imbalance. And that's really important. And so that's one of the things you can do to look at neurological compromise. But we have to make the case that subluxation is there. And we have to have that in our exam and in our re-exams to appropriately create a care plan and be able to monitor change. And the second is, hey, subluxation is there. Do we see any indicators that this trajectory of development has been impacted? Again, this is one of 8 hierarchies, but this is the foundation. This is where we look at primitive reflexes, and not I look at primitive reflexes so I can treat them, but look at them as a window into the system, right? And reassess them, not go treat them and do exercises at first. Sometimes it's necessary, but we need to know when it's necessary. And that's what we teach. Gross motor, fine motor, auditory verbal, eye movements and dynamic vision and visual cognition. We must start putting these pieces together. When we can do that, we can maintain our whole apart understanding, the big picture, the whole person, and we can start pulling down the pieces. We can understand that, like, this is the Big Dipper, right? Some of you have heard this analogy. You have to look for the pieces, but respect the whole of what you're looking for. We can have somebody with back pain or altered tone or behavioral issues or different things, and we can say, hey, if a subluxation is present in this person leading to this secondary condition, they may have indicators in the mechanical or structural. They may also have indicators in the autonomic nervous system or the neurological component, leading to evidence of that being on, heart rate variability, pupillary changes, or response, pupil response changes, or asymmetry, thermographic changes, leading, we would see altered proprioception. All of these things, if we have a structural leading to a neurological, that can impact the way the brain is functioning and developing, which can lead to learning challenges, which can lead to mental health challenges, perceptual challenges, socialization challenges. We have to be able to pull these pieces together, knowing that there are pieces to this puzzle, but we have to respect the whole. This is why I love collaboration. I love collaboration because we have to be able to say there are many pieces. As long as we're on the same page with understanding there's a whole, we really can find simplicity in this, in our clinical experience and our approach. We literally do this. I'm going to end here, but we literally do this with kids, adults, anybody who comes to us. They come with back pain. They come with behavioral challenges, socialization challenges, eczema. They say, can you help us? We say, listen, I don't know, but here's what I know. The brain's not fully developed at birth. We go through a trajectory of development. There's different things that impact that, physical, chemical, and emotional. We're in the business of looking at those responses that happen in the body as a result of stress that may be impacting the way your child and or you as an adult have moved through development, and therefore the tools you're using to process your world. The way we know is we have to ask and answer 2 questions. 1, are there indicators of input processing output challenges or autonomic imbalance? That stress response, is that there? If it's there, we got to correct that. We've got to work on that first. 2, do we see indicators of changes in the way that you, adult, are using your brain, you, child, or your child is moving through development? This is where we do our functional brain-based assessment. That's the second part of our question. This is how we find the simplicity. We make the case. We get a seat at the table. We get to be the foundation, not treating symptoms, not getting 3 adjustments to work on kids with eczema and people going, well, I tried chiropractic and it didn't work, right? Or with ADD, I tried that and it didn't work. We get to put these pieces together. Okay. Listen, this is the last thing I'll say. I want to say a lot of things, but this is the last thing I'm going to say. I'm going to say this. We have a lot of other professions now leading with the brain. We have educators, we have psychologists, we have medical doctors, we have OTs. They are leading with the brain. They are going, oh my gosh, there's this thing called the autonomic nervous system. And if it's out of balance, we must, and that's really the language, it's not that sophisticated. They're talking about it, right? We must look there first. We must look there first if we're having a secondary symptom of behavior or connection or executive function or whatever. We have to do this first. And that's the conversation. And they're saying it's this amazing thing, and it is. But the thing is, chiropractors, this is our domain. This is really what chiropractic is about. But we need to be able to communicate that, understand that, lead with the brain first. And when we can do that, these other professions are starting to they're starting to say what we've been saying, what is our philosophy. We cannot lose this opportunity. We need to be able to lead that charge, lead that conversation. And so that's why I say this is the best time to be a chiropractor. We have an opportunity right now to really help more people in our communities. Like we started talking about the massive amount of people that need us and that are looking, but also to really move the needle on chiropractic utilization, but not by changing our philosophy or jumping into the mechanistic realm, by looking at the whole person, whole apart, because the world, the professions, the communities, they're ready for it. But we have to just know a little bit more. We don't have to, neglect what we do and what we know and what our philosophy is. So thank you, everybody. We'll put our stuff in there. If you want to join, we are on a wait list for our certification this year. But we are trying to figure out if we can get some more people. If not, our next one's going to be next year. And you get certified in this and offer Brain Blossom program in your office. I highly recommend taking Dr. Marty's courses as well. We as an office are working through that, and that's going to be prerequisite in our practice for any associates that join. They're going to go through that as well with us. And then marrying these 2 concepts together, I think is like a really home run, and we're seeing that happen. Thank you all for supporting Sherman. That of course is, did I lose you?
No, you're still here.
Okay, good. You vanished from my screen. There we go. So Sherman, of course, is near and dear to my heart, and Dr. Marty as well is interested in supporting Sherman. And so thank you. I'm cool with taking some questions. I know in a couple of minutes long, but I'm sure Dr. Marty is as well. Thank you. Question.
Should I ask a couple of questions before?
Oh yeah, you should definitely ask a couple of questions. Yeah.
Before I put the final exam in the chat.
Yeah. Yep.
I heard you touch on some of these things, but I'm not sure you fully said it about how stress in early life has been shown to impact long-term neurological processes.
Yep.
And that the timing of the introduction of academic demand can create a stress response if a child is not developmentally ready to meet the demand.
Right. If demand is too high and a child's not ready, that's going to create more stress. And the timing of that can be the stress that causes the altered autonomic function. So that would be true.
Thank you. Interesting. I will put the final exam in the chat for you right now. And anyone who has a question, just unmute yourself.
Yeah. Unmute yourselves. Joy, I know it's late for some of you, but if you have any questions or comments, or you want to see more fun classes, let us know.
I have a pretty rudimentary question.
Yes.
Dr. Rosen talked a lot about the delta theta, alpha, beta, gamma, the brainwaves and the development of that, and talking about getting stuck in those developmental processes and becoming that primary piece, which of course, for me in the focus work mirrors the hierarchies.
Yeah.
When we talk about getting stuck in there and having those stressors, more and additional specific ways to, my term would be upregulate and increase those brain waves and that functionality in there and get the unstuck. Because Dr. Rosen drove home for me that we're really becoming hardwired based on stressors. And based on, getting stuck in that. So what are we seeing as far as being able to move that trajectory forward? Roundabout specific question.
So I have some comments, but I'll let you go first, Dr. Marty, unless you're frozen.
So, no, I'm here. I'm not frozen. So one of the things is that you have to make neuroplastic changes to change those patterns.
Mm-hmm.
So the number one reason they get stuck in that is because we burn out people's neurotransmitters. They got constant afferent impulse, and what happens is they creating neurotransmitters, more and more neurotransmitters, but they reach a threshold. The threshold gets higher and higher and higher. So what you have to do is first shut down the abnormal afferent impulses and actually create more positive pathways, both neurologically and also emotionally, and then physically pattern it. So you have to do all three things to actually make that change. It's just like training. It would be like training for a marathon. It's like you have to get the underlying functional structure, you have to get the nutrients in there, and then you have to get the motion. So it's all those three factors to make those changes and those shifts.
Perfect. Thank you for that affirmation.
Yeah, which is also why I love what Amy says about that. People coming to chiropractors and giving us 3 shots at it. It's like when I talk to people, and I love some of the things you said, Amy. I'll let you talk in a minute, but I just wanted to piggyback on 2 things that I thought were extremely important. And one of the things we teach in our class, and also, is your exam is so important. That is your baseline that you're going to base your care plan on. That is how you're going to determine neurological things. I always tell my students, I said, look, if Johnny stops throwing up after 3 visits, that doesn't mean you change his care plan. You change his care plan based on his neurological parameters. So you have to have an exam that fits your technique paradigm. So in my world, it has to do with dural meningeal. It has to be a structural exam. It has to be a cranial exam. I have to have neurological function. I do some of the same stuff Amy talks about. And that baseline carries you through that care, because I start with that exam, then 3 to 6 weeks later, depending on where I'm at with the kid and their care, I'll do a progress exam. And then another 3 to 6 weeks later, I'll do a re-exam. And what we're checking is baseline shifts and changes. So when we talk about the reported findings, we always tell parents, look, this process we're looking at is about 4 to 6 months to start with, not 3 days. So whatever your child has, colic or asthma or ADHD, whatever it is, it doesn't matter to us that it's about this baseline and changing that baseline. So that was a really good point. I love the way you said it too. So that was great. But I just wanted to piggyback on that because it's so important.
Yeah, no, I love that. And that's one of the things that I've loved so much about going through your work and like just listening to you speak, because we're really saying the same thing with a
Right.
little tiny bit different lens. And so we can gather more tools, to have an even better assessment really on all sides. But the thing
Right.
is that it's, you know, we see this in chiropractic, even people that are like really great at like, I'm having a whole pediatric office and I'm doing this and I'm not doing that. Then they look at maybe one of the indicators or two, like whether it's I'm scanning, I'm using thermography. I hear this a lot. Like I'm scanning, I'm looking at HRV and for example, and I incorporate those things, right, as a part of the puzzle. But if you're just making changes based on either symptoms, like, well, they stopped throwing up or, you know, symptom went away or whatever, or you're making changes just based on like, well, thermography changed or HR, these scans changed, but not really respecting the whole of all of the little clinical indicators, you're treating symptoms, you know?
Yeah.
Yeah.
It's about creating I mean, that's what I always say when I tell people to redo their like after taking my course, we always talk about do your exam over, redo your exam form, redo your exam form. Because when I look at my exam form, it's a picture. You know, you talk about the mental visual. It's like I don't look at it and go, oh, they had this test. It's like I have a neurological picture. And that's what's really important. You're creating a neurological picture. The broader the picture, the more you can help the person. And the less minutia you're dealing with, because you create a really broad picture, then you know, oh, well, you know, Johnny's still stuffy nose. It's like, yeah, well, Johnny couldn't walk or talk when he came in the office, and it's okay if Johnny has stuff, you know, what are you feeding him? You know, so it's like you open the picture, you open their minds, and you know, it happened to us the other day. We have this little boy, and I got to the point that we took care of the whole family, but I was a little frustrated by some of the stuff the mom was telling me. And she was telling my wife, who's Dr. Watson, who runs the office, a whole different story. It's like, she was saying, oh, I have this whole new kid. He's unbelievably sick, so all this. And she was going to be like, well, you know, he's sniffly. And she was kind of like hitting the minutia, and I had to reframe it. And Nancy helped me. Remember when he came in, he wasn't sleeping, he wasn't walking, he was banging his head. You know, there was the whole, she goes, oh yeah, all that stuff is gone. So you have to constantly reframe and open the picture up, because you're right, that's the way people will upscale chiropractic.
And like that, like understanding the parent neurology of parents are living in chronic stress now. When we're living in chronic stress, just as individuals, we have less activity in that prefrontal cortex. We have less ability to go into the future. We lose that visual imagery. And so they're like, okay, well, I forgot, even if it's like, I understand intellectually, well, he was banging his head and he wasn't walking and now he's just sniffly. We have to always understand where they are to be able to communicate with them in a way that helps them along. And that goes to Lisa Walsh's question here, giving them the short, and we talk about a lot in focus, the short term, give them the short term, but always maintain that picture, that visual imagery, that representation that you're giving them of like why we're doing this. But then you got to give them like stops along the way to grab something, because they themselves, the parents are living in chronic stress. And so, and one thing I just wanted to say on your, Dr. Lee, is that your question was, you know, you have to remember that when you look at like brain waves, or when you look at, if you're just looking at functional MRI, or you're looking at just the metabolic function of the brain, that's like you're getting this observation of what we're doing in here, right? Like how we're using this thing, right? So like, we have to understand, it's not that it's not like a pathology is creating those brain waves in a certain way. It's the way we are using and attending this brain that is giving us the observable measure of changes in those brain waves, for example, right? Or the metabolic changes, when they say, oh, we have, you know, metabolic changes here, or we have less activity in this area of the brain and more. It's like, right, because that's where we're using the brain. That's our attentiveness, where we're attending. And that can be because, so like, let's say we have an older kid or an adult, and we see these like these brainwave changes, right? Or abnormalities or inefficiencies or whatever. And we say, well, we've corrected subluxation, we've done all of these great things. But to Dr. Marty's point, yeah, but they've become embedded. It's the way they process. It's like when you meet somebody that's like, they have a great life and their first response is like always negative, right? They are embedded in that neural processing. And we have to create neuroplastic change to get them to use the system differently. And then we will be able to observe the changes, whether it's metabolically or looking at the brain waves. That's why I'm not a huge fan of only like neurofeedback. We have to look at bottom up and we have to look at top down. We have to be able to look at the age of the person and their developmental trajectory and be able to put the pieces together appropriately.
So I have a question, actually, it's kind of for everybody there too. So when I started practicing, how you built your practice was you got the parents in, you educated them, and they brought the kids in. And it was great. And because once the parents brought the kids in, they were totally on base. They understood it. Now what happens is the opposite, especially in my world, because people find me online, they bring the kids in, the parents aren't under care. And so I find that much more difficult. But I like what you say is that, you have to understand what the parent's stress is, because I still have, and I've been in practice a long time, and I'm not really trying to build a practice. So if parents come in and they don't bring their kid in, I mean, the kids come in, they don't bring the parent in, I don't even care anymore. It's like, I'll just take care of the kid. You can stay home, or you can have, whatever, you bring the au pair to bring the kid in, it doesn't matter. But do you guys notice that in your practice? And if you're building a practice, what you really have to do is go back and feed into what that parent's stressor is, because, and it just happened again, I have this mom, I've been taking care of both her kids, and I've taken care of both the kids probably now for 8 months. And now she finally decided to come in, and it's like, it's very hard to back educate. So it's really important, I think, in the beginning to get where the parent's coming from stress-wise also. And it's always easier if the whole family is under care. Of course, but is that something you notice a lot more? You get the kid coming in first as opposed to the parent?
In our practice, because we lead with the brain in all of our education, and like that's what we teach our doctors to do too, is I mean, we're like, it's almost always the kid first, the kid with a challenge first. And then the parents like, oh, well, I have these other kids and they seem to be developing fine. And maybe they are, or maybe they actually have some other things that they didn't notice. But when we teach them, they're like, oh, I actually noticed this. And then they get the other kids, and then the parents are last. And so like, I take that, I think that's great, because I'm like, great, I'm getting the kids. And I want to create, and we create in our systems that, some ability, we try to make it easier for the parents to get in. And we talk to them about, like, we do something, brain-based parenting. We talk to them in our table talk and education on that, because it's like, but if you're still in chronic stress and you can't connect with the kid and advocate for them in a certain way, then that hinders the process,
Absolutely.
Yeah.
No, it is great. And we used to, sometimes you have a parent, like I had one parent who only brought, her husband came in, she came in, and 3 of the 4 kids came in. And the other kid wasn't coming in. So one day, my wife were talking about it. So we said to her, I said, we really don't get it. We really don't understand it. Finally, about 5 months into it, she finally brought the last kid in. And on the case history said, well, what, we don't ask symptoms. We just ask point blank, what is the reason for coming to our office? And she wrote down, she said, well, I decided to bring Maeve in because I thought it would cost me more for psychiatric care when she realized her whole family was under chiropractic care and we left her out than it would to bring her in for care. So we brought her in for care.
Well, good.
I said, I don't care.
I mean, that's probably true.
Yeah, probably is true, right? All my family was under care and I wasn't.
Yeah, just not me. Yeah.
Because she was the one kid with no symptoms, that's why she didn't bring her in.
Right. And that's the thing, when you can lead with development, I find it so rewarding, because like you teach parents about development, and then they get it. And then they start going like, oh, okay. And then you're like, well, this applies to any age. And they're like, well, I process that way and I do this. And then so it's about the brain, and chiropractic is the clinical tool. And that's really a lovely way to practice. And so, any other questions for us or comments or anything like that?
There are 2 things in the chat. During your presentation, Dr. Carolyn, sorry if I'm saying this wrong, Gochi, made an observation about how she's seen more adults that are under 40 years old being diagnosed with ASD. If anyone else thinks this is odd.
Well, I just think I think we're having, I've seen that too, and ADHD.
ADHD, big one for adults.
And like so any of you who've been in any of our classes, we talk about like that 30 to 40-year-old woman, and it could be a man too, but it's really typically a woman who's like chronic stress, and their clinical findings are very similar to traumatic brain injured individuals. And so then of course, and it's really just looking at stress impact, and then even with a whole brain development, deflection down and stress response, overactivation of limbic. So we can see regression as well. And that could be, we could look at that as traumatic brain injury. We could look at it as ADHD. We could look at, all these different things. So yes.
And then Dr. Lisa Walsh wants to know, what are some communication pegs you give to parents that stress the importance of long-term care beyond the symptoms?
Well, I think we discussed that, but I'll let you, if you want to say anything else on that, Marty. But
can you just repeat that question? What was the first part of the question?
What are some communication pegs you give to parents that stress the importance of long-term care beyond the symptoms?
Well, the first thing is when I never adjust on the first visit. Ever. So I do my whole exam. I explain to the parent, look, we're going to do the exam first visit. Once we do the examination findings, we're going to have you come back on the second visit. I'm going to go over the findings we talked to you about, how you can help your child. After that first visit, I may give them a brief input into what chiropractic is. We also tend to give them some literature that we've written ourselves. We write our own pamphlets. So we'll give them like a welcome to the office pamphlet. On the second visit, what we also do is I will sit down with them, and first thing I do is I go over their exam, and I talk about the neurological indicators I found and the baseline. And then the next thing I say, look, what we really want to do is, I understand that, you came here because Johnny has colic or ear infection, whatever it is, but this is his neurological baseline. What we want to do is really change his neurological baseline. And to start to change that neurological baseline at his age, it's going to take at least 4 to 6 months to actually start to make an input, so that not only do we get rid of this aberrant pattern, but we help to establish a normal, more positive pattern. And then when we get to that point, we can talk to you about wellness care. So that's how I start my exam. Start my reported findings. And then I go into the minutia of what I found on the exam and, the visit frequency and all that. So I've already told them that we're looking at a 4 to 6 month process to just change the pattern, make a neurological input. And I start at that baseline. And then I just open up the world for wellness care, because they're not anywhere near ready for that, but just let them know when we get to the point. And then during my care, what's really important is, as I'm doing my progress and re-exams, I reinforce what I'm doing and why I'm doing it. So on my re-exam, my progress exam, the first thing I'll say is, these parameters have changed so far. Johnny's neurological, state is doing better. And that's actually really the first time I asked them about the symptoms. I don't ask about the symptoms. Parents will tell you, but that's the first time I may say, how's Johnny doing? And then once they tell me that, I say, great, but this is neurological baseline hasn't shifted yet. So I'm going to keep him on this visit frequency for the next 4 weeks, and we'll do another progress exam. So every time I kind of re-up when I do my exams to let them know what's happening, what the baseline is, how it's changing. And I will ask about the symptoms, because parents are interested in that, but that is secondary to what I'll do for my care plan. And then I move that through. And then when I get to that 6 month period of time, and I say, look, it looks like Johnny's doing a lot better. I'm glad he's feeling a lot better. His neurological baseline is changing. We should talk about, what you want to do for continued care, or whatever you want to call it, wellness maintenance care, but to maintain his healthy nervous system for the next, phase of his life. And that's kind of how we do it.
I love it. I would say we're very, very similar. It's just always coming back. This is the thing that we're so congruent on, is that there's no guessing, and we're always coming back to those re-exams, and right. That gives us an anchor to guide our clinical care, of course, first and foremost, and then guide the conversation of reintroducing what we're doing and why we're doing it, and then maintaining that big picture understanding as well. So, yeah, love that. So just why I'm always listening to your stuff going, yes, I love this.
Well, that's why I love it with adult patients, because adult patients sometimes really look forward to their exam. Like sometimes I may space it out and I go, wasn't I supposed to give an exam last week? And I'll look, oh, you're right. That was your 8th visit. Yeah. And they look forward to the exam and they want their report. Like they sit down, how do they do? I'm like, well, I'm like, well, how do you feel? I feel great, but how do they do? And they've actually already shifted. Like they've been feeling good for 2-3 weeks as far as whatever symptom they came in, but they want to know how their neurological outlook is. So they already want to know how they do. And I always find that interesting. I like that when you do it that
great.
way. Yeah.
I see there's one more question and then we'll probably call it a night. So can a baby have great cognitive development, but sleep is not great by 20 months and cannot sleep alone? Yeah, I'll go and then you go.
You go. Go ahead.
Yeah. Okay. So can a baby have great cognitive development, but not sleep great by 20 months? Yeah. So, Yes, but I think there's probably, in that case, I would always go, but I would like to take a closer look because I want to know, like, what does not sleeping well actually mean? Like, are they, like, how often are they waking, and what are they doing when they wake, and what are their movement patterns, and like, what's their digestion like, what's their skin like? I would question that statement of we're on track. I would want to dig in a little more with an exam to go like, and is it a typical waking sleeping pattern, or is there more sympathetic activation and we need to address that? And not sleeping alone at that point, I have no problem with, because that's a typical, I think, for a child to be with somebody sleeping at that time. But again, I would say, but what does that mean? Like, can they not sleep when they're not being touched? Can they not sleep when they're like, what? There's more questions.
Yeah. I actually agree. So with my practice paradigm, with the technique I use, we have a system that checks organic imbalances. So if someone's saying, oh, Johnny's not sleeping, or not, I keep picking on poor Johnny, but if the kid's not sleeping a lot, I'm going to ask what time of night, how often they wake up, because I'm going to look at a circadian rhythm chart and see if they keep coming up at the same time, what organ system is under stress. So that may fall back into digestion. It may fall back into sympathetic dominant pattern. So again, just like Amy said, I'm going to ask some more questions. I want to know if it's same time recurring. As far as sleeping with somebody and touching, I don't worry too much about that, as long as during the day the child is active, motility wise is good, cognitive is good. So I want to check sympathetic and parasympathetic balance. I'm going to check pituitary glands to see if it's working. I'm looking at circadian rhythms to see what organic issues are coming up. And I also have another system that I use to help determine organic imbalances, because it may be simply that the child has a liver issue, that the liver is hypersensitive, and that'll wake them up at 2 o'clock in the morning every morning. So that's where I go and look at that next phase. Start with the neurology. I start with the neurology, work down to the organic part. That's how I do it.
Love it.
Yep.
Love it. Love it. Love it. Okay. Well, that was fun.
That was a lot of fun. And it's even almost past my bedtime.
Oh, I know. I mean, it's way early for me. So thank you for staying up late. Next time we can do it earlier, or we can do a different time. But yeah, we'd love, I'll let you connect with how do you check the organic part. I think that's probably something, I know you talk about that more in your classes.
Right.
So I would recommend connecting with Dr. Rosen or taking some of his classes, because I know I was fascinated by that and the stuff that you teach in your classes. So,
and for those of you who are just listening in, should just Google circadian rhythm chart, and you look at the circadian rhythms, and it'll give you the different types of day when different organ systems are most active. And if you have a kid that keeps waking up the same time, take a look at that organ and see if it's something that you might want to do nutritionally or functionally to help deal with that.
Yeah. Love it. Okay. All right, everybody. Well, thanks for being here. Thanks for staying up late, all of you East Coasters, including you, Dr. Rosen. And I look forward to lots and lots of collaboration. And I just appreciate your lovely brain and your knowledge and experience. So everybody, thank you. Have a great night. Great holidays.
And thanks for setting this up, Amy. I really appreciate it.
Absolutely. I look forward to more.